Hola, hola.
I'm short. I'm covered up with the podium. Yeah. Good morning, everyone. Welcome to the public forum. at the 11th IFNR 2023 conference for neurorehabilitation. This conference has been always special because it gets better and better with new vision. In this public forum, we have a special novel idea of getting 11 disorders on one platform with all the stakeholders involved. That's medical professionals, persons living with the disorder, NGOs, and support groups. Without wasting time, I'd like to mention that it's a privilege to be here to moderate the session and, more importantly, to introduce Dr. Nirmal Surya. It's quite an easy thing for me to introduce him because everybody knows him. But I'd give my feeling, what I think, what Dr. Surya has been to the area of neurology and neurorehabilitation. He is a powerhouse of energy, a lighthouse as a guide, and a visionary as he has new ideas coming which are different, novel, and more importantly, very, very appropriate for the cause of neurorehabilitation. Dr. Surya, privileged to invite you. Please initiate the public forum with the 11 disorders. Thank you so much.
Good morning. Hello. 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 Yeah. Good morning, Vidya. Thank you very much. The power comes from the car battery. There are batteries which charge through the wheel. So the power comes from you guys. So you don't know that you are transmitting energy to me. Inadvertently, I am taking up that energy from all of you. And that's the reason I'm able to do the work. So I'm a bit disappointed because I don't see many support group representative here at the moment. I thought that this is a greater opportunity for them to raise the voice when we have the expert. So they should have come in large number. I kept this big hall purposefully because I thought there would be hundreds of people coming here to participate and raise their voice. Now, this is a very, very important session because the doctors are treating, but the doctors are not, they are human beings, but they are treating the disease. They understand the disease. They know that what is happening to your brain. They know that how you are recovering. But what you are feeling, what is your position, only you can make understand. Sometime I have a small burn 3 days ago. Now this is so small. There is a blister for last 3 days. But every time I speak or every time I hold something, it is disturbing me. So if a small blister on an index finger of left hand, not even the right hand, can disturb me most of the time while I'm working, understand the neurological disability a patient has, how much they must be feeling and wanting to say, speak, and other people hear. And that's the reason this sort of a platform is important. And I purposefully have organized this time with Vidya and Manish, joint support group session, because you know that there are diseases which are affecting the brain. There are different methodologies. So be it a traumatic brain injury, or be it is a stroke or Alzheimer's or motor neuron disease, ultimately it is the brain which is affected. The mechanism may be different, the lesion may be different, and your symptom may be different, but there are common things. The brain is common, which has been affected, and there are common symptoms and common problem everybody has, which we want at least to be addressed commonly. Why commonly? Because if 20 organizations come together and come out with 5 important points that these are the must we should get. Then it is our voice. And the voice is only heard. It's like same, one finger or full hand. So your voice is only heard if all of you come together along with the neurologist and one word that this is what at least minimum we want. And if we are able to do that on this platform, the life and disability will differ. I will not say that it will change, but it will differ. It will have many more smooth roads, because if your road is smooth, if it is not smooth, how good you may have car, it will not run better. But if road is smooth, even a car which is not the top of the end can run fast. So that's the message which I have. Now, next 3 hours, you all are going to discuss. And I'm going to give you a new idea today. Vidya said he comes out with some ideas. So the idea is, and I'm very serious. It's not an idea. It is a very serious point which I am talking today. And please think for 3 hours, and end of it when I come back, let me know that what do you want to do. The idea is that IFNR lies with you guys. You all come together from all over India, all support group, come together, and you are going to form an Indian Federation of Neurological Association, which will be for patients and family. So this will be an organization which will be independent, yet it will be a part of the Indian Federation of Neurorehabilitation. This will have all support groups from India representing. One of those support groups will be the council member. They will also be invited into the IFNR board meeting. And once this is formed, it will take 3 months or 6 months. You all stakeholders come together, we'll form a constitution, get it registered. Once it is formed and we start working, I will liaise this with the European Federation of Neurology Association of Patients and Family or Caregiver. So with that idea, I will leave from here, and I would really want to hear from you all guys that are you really serious about the neurological problem which you have, or you want to fight individually as individual association. So if you feel that this platform is worth, please come back to me. I'm ready to help you out. I'm ready to fight it out and have your message been heard to the people who are deaf so far. Thank you very much.
Good morning, sir. And I think he deserves a better round of applause for all the work. First of all, I would like to congratulate for the successful conduction of IFNR meeting, a brilliant scientific meeting. And without any further ado, sorry, I think I missed that. So moving on with the current program. So we have, if you can just scan this QR code and share it with the other groups and the other stakeholders also. Now this will take you to a very simple 6-point questionnaire. This is just the beginning of this is a sensitizing type of questionnaire, but it's a very important one. It will show your level of participation for the current meeting. And I would like that many and most groups should be covering this. So yesterday there was an overwhelming response. We had a 2-hour period where it got the maximum time responses, so it was blocked. So we had to increase the number to a substantially high thing. So I want more and more people to participate. So coming back to the meeting, that's what we are calling it, Neurons Ki Awaaz, Public Ki Zubani, because it's a combined type of project. I hope everyone has scanned it. Yeah, okay. No, I hope it is working. They haven't played a foul play with us. Okay. So me and Vidyaji would be convening the whole program, but very importantly, now on we will be having all the 11 these groups coming over and talking about the important 5 aspects. These 6 aspects are to be covered predominantly for these chronic neurological disorders. That is, what are the types of impairments, how accessible, affordable rehabilitation facilities are available and what they should be, and what should be an ideal team composition. They should mention the challenges and the solutions for disability certification and insurances. They should cover newer avenues, what the role they are playing, and in bridging that gap, like teleconsultation, telerehabilitation, robotics, and etc. Social support which is available. Many of you have been doing it for decades. So we want to learn and need to incorporate that in those important points. And what is the role of ambassadors in actually capturing or creating that awareness and advocacy? So most important thing is please stick to the time. We have 10 minutes for the group. If we are overshooting the time, I'll be rude. I'll be putting the buzzer continuously because the other group also deserves the same time. So with this, I would like to start with the first group, that is the stroke. And may I invite Dr. Biplab Das and Mr. Wilson Gaikwad. So they as a group should come forward and then talk about there. And Mr. Prasanjit Chakrabarti, is he here? So, okay. So let us start. Dr. Biplab, please.
So Wilson is here? Yeah, please. Yeah, you can join. Come. Yeah, thank you, Dr. Manish, and good morning, everyone. And Vidyaji, and as you already said, when I look in Nimal Star, there's extra energy I get, actually, really. That's wonderful. Okay, so this is a wonderful platform where we are talking about not only stroke, so any neurological disorders, especially in short of how they are going to change, how they're going to help for public, right? So as far as stroke is concerned, you see why we need a public awareness, why we need involvement of stroke support group or some organizations. Stroke is something which can affect anyone at any time in a fraction of a moment. You are doing absolutely fine. In a fraction of a moment, the whole life, whole system can be dramatically changed. The person can become bedbound. So the wonderful things which can happen is that now, if the public knows the early signs and symptoms of a stroke, they can identify symptoms of a stroke, and they can reach to a nearby stroke ready centers. That day I was just referring to a young chap. He was around 28. So in the middle of the night, he had a stroke. Luckily, his wife identified the symptoms and he shared the symptoms. He discussed the symptoms in some other group. That's a WhatsApp group. But some of the members were part of a stroke support group. And that's how they come up to a nearby stroke ready centers. And the guy is now walking, talking, doing his normal activity. And that signifies the importance of a stroke support group. Because for a layman, for a public, he or she may not know the symptoms. And if he knows the symptoms, he does not know where to go, what to do in that emergency, right? So that uniform system, the system, where a layman or a person can refer or can take that advice is not there. So where IFNR can play a major role. Okay, so coming to the magnitude of why we need this system, because stroke is a very, very common, disorders, medical emergency, which can happen, as I said, to anyone. So to say the data, Dr. Pandian was also presenting the same data. So in every 2 to 3 seconds, someone is having a stroke, right? And every 3 minutes, someone is losing life because of a stroke. So stroke is very, very common. That's why we need to know about stroke symptoms. And if someone has stroke symptoms, an awareness program is placed, the person can reach to a center. But if you look into the worldwide data, not only in India, even worldwide also, the stroke awareness is so poor that hardly 5 to 6% of patients who are having a stroke, they reach to a center where proper stroke treatment is given. That's very, very unfortunate, but that's the real picture. So from here, you can make out that, more than 90%, I repeat. So people, they don't reach center within the golden time. And that's saying, so it does not mean that, more than 90% of patients are going to die because of that. So because there are so many other treatment available, which is beyond this golden time, because more than 90% patients, they might be coming with disability sort of things. Okay, so that's the role of IFNR, where that's the role of neuro rehabilitation. So you can, from here, you can make out the magnitude of magnitude of persons who require the neuro rehabilitations, very intensive way, very uniform, proper way. And the role of, stroke support group. So I would like to invite you for your inputs also. Yeah, Wilson, please.
Thank you very much for giving me this opportunity, Dr. Surya, the moderators, and Dr. Biplab Das. And first of all, as I'm representing myself for Stroke Support India, I would like to thank Mr. Hardipji Sodhi, who is running this stroke support group. That is what Dr. Biplab Das has told. What is the role of a stroke support group over here? Now, let me introduce myself that I am a stroke affected person. I'm a stroke warrior. I did happen to get a stroke some 2 years back. And by almost 6 months, 7 months, I was bedridden, completely on the bed. And after that, then I had to get a little bit sit on my bed. Then I happened to walk in my room. It was difficult for me even to go to the washrooms. So even to take a bath, it was a challenge. So it was my family, my wife, my immediate mother and brother, they had helping me out in my daily chores and all. So it was difficult for me even to hold a pen. As far as vision is concerned, I do not have a peripheral vision. Now, if I'm looking in front, I cannot see Dr. Biplab, who is standing over here. So these are some of the challenges. Okay, now you can find me very much strong, fit, healthy, standing. Yes, I will tell myself that yes, I am also running marathons up to 21 kilometers. And that is the recovery what I had actually got. I thank basically for all the stroke support group, basically the Stroke Support India, what has actually helped me. Moreover, I have little bit achieved. Of course, the what you call as the recovery is almost 80%, 90% or 95% what you can see right now. Yes, mentally I'm having a little bit challenges. I am a advocate by profession, and also I had been working as a microbiologist. But while speaking, there were challenges that I could not speak. There was a tongue which was very much hard to have the movements and my words. It was like someone who is a drunken person. People could see me that I am a drunken person who is talking something nonsense or something like that. Or moreover, some of my close friends who knew, they said that this guy is unnecessarily acting too heavy or too smart, and he is trying to make a European or American accent. Well, it was not like that. I myself am very much Indian, and my English is very much this thing. But yes, due to the problems, I had that things. Moreover, as far as speech was concerned, still now I feel the temperament which is causing a problem. I do get very much excited. I do get very much hyper. While arguing into the court, the judge has to tell me, Wilson, calm down, be a little bit less. So that was the challenge that while going on and on with my case and argument, I go up to a very hyper level. Moreover, that is what some challenges are there. Some of the achievements are there, which I have definitely achieved because of some Stroke Support India or the Stroke Support Group, the groups which has been the peer groups, where there had been discussions, there had been I will thank Dr. Biplab also, because he is also a part of a stroke support group and he has been helping out. So as an achievement, we can say that definitely there is recovery which is possible up to 90% or even 95%, where I myself am an example of that. Of course, there has been challenges, there is still growing. And as an achievement, I would like to mention to the forum that yes, I have also started writing, where my physiotherapist told me that you start writing, and I've also started written the complete Bible with more than 1,000+ pages. So this is what my journey for recovery is. And I thank you for giving me this opportunity. Please.
Thank you. Thank you very much.
Thank you, Wilson, and thank you, Dr. Biplab. Dr. Biplab, I need you for a minute. People have been following global guidelines, and this man, I think, he's really an inspiration for many, and he has come up with an acronym. I would like him to just talk briefly about a minute about that acronym, and because see, disability prevention and is very equally important as the rehabilitation. So he has come with that acronym to identify early symptoms of stroke so that the people can be brought to the emergencies and early thrombolysis or early effective therapies can be offered.
Yeah, thank you, Dr. Monish. It's not something rocket science sort of things. We had a discussion, so that is always there. Fast is always there. So that is, we don't deny, it's all over the world is fast. So we were thinking, Dr. Dhiraj is my mentor in my residency time. So we thought of what we can come up for Indian persons, okay? So that they can, get attached to that one. Is there any more word which is more catchy for them, for a public? Because if you go to the rural or lay persons, they may not know fast. Fast is a very wonderful name, but it's in English. So I thought bachao is a Hindi word, okay? So we come up with the bachao, which stands for bahu, means your weakness in your hands and all. So bachao word itself signifies some of the symptoms of stroke. Similarly, in English, we have save me. So this is because of short of time I will not take. So we are trying to change, translate and come up with some very specific word, which is very catchy for different regions, say for Assamese, for Bengalis, for Tamil and Adisau. So translating this one so that the people can get associated, for a normal layman in a rural area, they can get associated. And somebody is having this problem, they can reach to a nearby center. The primary purpose is to raise the awareness. Thank you very much.
Thank you, Dr. Biplab. I think he deserves a round of applause for all this. Now we have Dr. Dheeraj Khurana, Professor of Neurology at PJ Chandigarh. He has joined recently. He would be joining me for the session of multiple sclerosis. Can we have his audio?
Yeah, hi. My audio is on. So you want me to start up? Okay, first of all, hello everyone, and sorry I could not make it. Manish and Biplab prior to this session. It was first of all, it's a great initiative here in the IFNRCON to have patient support groups getting all together here. And just like I heard, first of all, I salute all the warriors of all the chronic illnesses and chronic conditions like stroke and MS. They are champions, I would say. Champions होते हैं, उनका एक purpose और एक माहौल ही कुछ और होता है, because champions are the ones who represent कि हम एक मुश्किल से निकले हैं और उसको जीत के निकले हैं. So just like I heard the stroke champion, even MS has all the champions who are fighting, who are dealing with all the problems of MS. And it is not just one problem, it is a huge problem that we face with MS. And jitne bhi warriors hain MS ke, they deal with it on a day-to-day basis. So main itna hi kehna chahunga ki multiple sclerosis is one condition जो कि एक attacks में आती है. We all know about it. And it's very important to recognize it early. So जिसको भी ऐसी कोई condition लगे जिसमें आपको लग रहा है कि MS जैसे symptoms हो, mainly vision problems, or sometimes you may get weakness of the limbs, always consult the neurologist or a physician and keep a suspicion high, because this may be early treatment बहुत जरूरी है. MS की early treatment protects you, and now we know research has reached a level where we can start very early, we can detect the disease very early and treat very effectively. क्योंकि हमारे अपने experience में, and I'm sure my colleagues Manish, who's here, who also deals with multiple sclerosis, we see it on a day-to-day basis that patients जिनको हम we start early and we start effective treatments, they do very well. In fact, for years and years, they can live. And in fact, once a certain threshold is crossed, we believe that आगे disease बढ़ती भी नहीं है. So it's important to start early treatments. Do not delay treatments, because very safe and effective treatments are available. And as regards support group, I think it's a great initiative to have support groups across the nation getting together. MS ke support groups we have multiple, we have our own local support groups, and I lend my full support to this initiative, where we can have, which Dr. Surya has initiated. My congratulations to Professor Surya to have started this initiative. और अगर ये सारे support group एक बार एकत्रित होकर, we can create a big huge voice, and this voice is very important, because this is what leads to change, and change is what is needed in conditions like MS. We need to sensitize the world, the public, and especially the Indian public, and the I would say authorities, which have to recognize people with MS and the special needs of people with MS. Till now, I see that there is no significant change in the rulings or change in the laws which govern disabilities, and which is there in the West. And MS is still not categorized into something where a special as a special condition. And I would look forward and in the future to see that, and I can see that happening only when we have groups coming together and lending their voice and making their voice heard, making their voice louder. So with this, I would say congratulations again on this wonderful initiative. And
Thank you, sir.
Yeah.
So carrying forward, I think multiple sclerosis, the most important thing is that it affects the young people the most. 80 to 85% of the cases, the relapsing remitting cases, they are the young people, 20 to 40s. So that's I call MS as a costly disease. Why? Right from the diagnosis to the treatment to the indirect cost because of the loss of employment. Now there are certain tools which we use to address the progressive form of MS. There, not only cognition, because that is something which is now seen to be involved early on. So that affects your employment. So this is an indirect cost. At one side, your expenditures are going skyrocket. The second thing is you are not earning also, either because of the disability or because of the stigma also associated with MS. And many a times people come to us that they can't discuss, they can't disclose in their workplace. And because of something called as invisible MS, there are certain symptoms like fatigue, some pains and everything, they can't discuss with anyone. So unless, on the other hand, we have patients who have actually, their colleagues have been so supportive that, okay, if you are not feeling okay today, there are good days, there are bad days. So on the bad day, they're gonna cover up him or her. So things change tremendously for these people. So that, sir, what he was talking about, the sensitization of the public about all these issues. So every year, World MS Day is commemorated based upon some theme. And invisible MS had been a very important theme for a very long time because it's still unaddressed. So similarly, neurorehabilitation, because exercise, increased physical activity, and many of the symptoms like spasticity, these are to be dealt as a team effort. I have proposed an atomic a model of comprehensive care of MS. Patient and the primary caregiver, they remain as the nucleus. The other people are in the outer orbits. Depending upon the particular need of the person, they can come and towards the nucleus, and then they can change their roles. So with this, I would like to invite the next group. Thank you, Dheeraj sir, for joining in, and thanks for the wonderful insights. Can I have the... So with this, we move to Parkinson's disease. We have Dr. Atul and Mr. Mohan over here. Yeah, so Dr. Atul Thakur and Mr. Mohan Pote, please.
Good morning. I'm Atul Thakur, representing Parkinson's Mitra Mandal, and I'm going to share a small story of this self-help group. It was almost 25 years back. Mr. Sharat Chandra Patwardhan and Mr. Shende started this group, and ever since the conception of the group, our motto was Parkinson's Saha Anandane Zaguya, means let live happily with the PD. We are the facilitators. We organize activities in such a way that patient and his family members get information on various aspects of the disease. However, at Parkinson's Mitra Mandal, we are not just the information provider, but we host various activities where our patients, whom we address Shubharthis, manage their Parkinson's disease gracefully. To mention some of our activities, we hold regular monthly meetings where medical and paramedical professionals, experts, physios, speech therapists, dietitians, yoga gurus, they guide and address the queries of patients. We also hold guidance lecture on geriatrics and issues of caregivers. One of the objectives of the group is to engage our Shubharthis in recreation and entertainment activities. Since last 14 years, many of our Shubharthis participate in the dance session regularly. This has a magical effect on disease management. Professional choreographer in the city, Rishikesh Pawar, conducts this activity free of cost. Every year we organize one-day picnic, which is yet another interesting activities for Shubharthis. They love to join this picnic in spite of the movement disabilities. We have published a couple of books. Most of them are compiled ones or translations. They provide information on Parkinson's management and are user-friendly, hence popular among Shubharthis. The souvenir is published in the annual get-together on the World's Parkinson's Day. Our work is recognized by society. We are recipients of the prestigious Sangharsha Sanman Puraskar and few others. We have been granted the permission by American Parkinson's Disease Association, APDA, to translate their books in local language. We have adopted modern technologies to reach globally. Our website, YouTube channel, Facebook page are doing well. Recently, we were informed to have 30,000 plus viewers. In pandemic, we started Zoom meeting, and all our meetings and discussions used to take place on Zoom app. We are now too accustomed to Zoom meetings and WhatsApp group, and now it's our daily virtual seminar hall, which keeps us close to each other like a big family. Friends, at last, on behalf of Parkinson's Mitra Mandal Pune, I assure that Parkinson's Mitra Mandal Pune would appreciate in the activities of this forum. Let's go ahead and serve the people with neurological disabilities to improve their life, their quality of lives. I thank again the organizers for inviting us and wish the great success to their DEEM projects. Thank you all.
Respected doctors and audience here. First of all, I appreciate the efforts of your team who has arranged this program. In 2016, while working in a state bank, I suffered some problem. I was unable to hold pen for writing. My handwriting was becoming shabby, but one day I could not hold the pen. So we started to meet doctors. For year, we एक साल भर मैंने 4 ऑर्थोपेडिक, फिजियोथेरेपिस्ट और एक साइकेट्रिस्ट इनसे ट्रीटमेंट ले ली। आखिर में एक बहुत ही बड़े न्यूरोसर्जन डॉक्टर, उन्होंने जैसे हमने उनके केबिन में प्रवेश किया, बोले कि आपके सारे रिपोर्ट रख दीजिए थैली में ही, आप 2.5 साल से पार्किंसन आपको शुरू हुआ है और ये पार्किंसन जो है आपका जिंदगी भर का साथी है। तो उनसे ट्रीटमेंट से, मेडिसिन से मैं अपना रेगुलर काम अच्छी तरह से करने लगा। 2018 में 2 साल के बाद मुझे एक नई तकलीफ चालू हो गई, जैसे कि खड़े खड़े चलते चलते मुझे झपकी आने लगी और 8 घंटा 10 घंटा नींद के बावजूद भी मुझे फ्रेश नहीं लगता था। तो मैंने क्या किया, जो मेडिसिन थे वो आस्ते आस्ते कम कम करके एक दिन मैंने टोटली स्टॉप किया। घर वालों को भी नहीं बताया, डॉक्टर को भी नहीं बताया। उसके बाद घर वालों के ध्यान में ये बात आ गई, 1 महीने के बाद मुझे फिर पुरानी तकलीफें चालू हो गई। तो बोले डॉक्टर को मिलेंगे, मैं सीधा इनकार कर दिया, नहीं मिलूंगा डॉक्टर से, वो तकलीफ होती है, और मैं दूसरा कुछ इलाज ढूंढने लगा। तो ऐसे एक मेडिटेशन ग्रुप में एक डॉक्टर ने बताया कि आप पूना के पार्किंसन मित्र मंडल ग्रुप से ज्वाइन हो जाइए, आपको बहुत सपोर्ट मिलेगा, लाभ मिलेगा। तो मैंने हाँ कह दिया। शाम को ही मुझे डॉक्टर शोभना तीर्थड़े मैडम का फोन आ गया। उन्होंने बताया कि देखिए आपके 4 साल स्टेट बैंक में बाकी है, आप डॉक्टर से फिर मिल लीजिए और मेडिसिन चालू कीजिए। आप बहुत ही आत्मविश्वास के साथ ये सर्विस पूरी करेंगे, मैं गारंटी देती हूँ, लेकिन डॉक्टर से मिल लीजिए, मेडिसिन चालू रखिए। तो उनका सलाह मानकर मैंने फिर चालू किया। जैसे हमारी उम्र 58 साल हो गई, स्टेट बैंक ने मुझे 2 साल का एक्सटेंशन दे दिया और अभी फिलहाल मार्च में 2023 मार्च में मैं पूरा 60 साल का उम्र में 40 साल सर्विस पूरी करके स्टेट बैंक से रिटायर हो गया। ये सारा श्रेय मेरा जो ग्रुप है, शोभना मैडम का सपोर्ट जो है, इनको मैं देता हूँ। अभी नए पेशेंट के बारे में मैं बताता हूँ। जैसे भी मुझे मालूम पड़ता है कि अरे अपना ये दोस्त, उसको भी पेशेंट पीडी हो गया और कोई पहचान वाले हैं, वो बताते हैं अमुक अमुक, तो इसमें निराशा उनको बहुत घेर लेते हैं, घर के बाहर नहीं आते। तो उनको मैं मिलता हूँ और ज्वाइन कर लेता हूँ ग्रुप में, उनमें बदलाव आता है। कभी कभी हम लोगों को ऐसे खोटे लोग मिल जाते हैं कि जो बोलते हैं हम आपका पीढ़ी 101% अच्छा करेंगे। हम सबको उनसे बचने की सलाह देते हैं। धन्यवाद।
I'm privileged to invite Dr. Deepak Palande and Dr. Kavin Devani for the session on traumatic brain injury.
Good morning. It is an honor to address this gathering, and I congratulate for this endeavor. And I'll be speaking on traumatic brain injury.
And as estimated, it is a leading cause of mortality and morbidity in young individuals. And it is rightly estimated by WHO that it is going to, India is going to be a capital of traumatic brain injury. And it is most commonly seen in age group of 18 to 45 years. And we all know that victims survive with significant disabilities. Road traffic accidents are responsible for the major chunk of traumatic brain injuries. And according to the 2022 statistics, every minute, 5 to 6 people in our country die because of this. And I am very sure this pyramid is an underestimate of the actual figures, with 5 lakh people actually dying and 30 lakh people actually requiring hospital admissions secondary to traumatic brain injuries. Just to sensitize you about these, the traumatic brain injuries can be closed and penetrating injuries. And they can also be classified as primary or secondary depending on the mechanism of the trauma. The primary injuries include traumatic subarachnoid hemorrhage, extradurals and subdural hematomas, contusions, and diffuse accidental injuries, with subarachnoid and subdural hemorrhages being very prevalent. The secondary brain injuries which follow the primary is secondary to generalized edema and hypoxic ischemic brain injury. And so our main aim or objective is to prevent the secondary injuries to the brain by maintaining adequate perfusion and oxygenation. We all are aware of this pre-hospital management. The care should initiate at the very moment of the injury. And we intend to maintain the adequate airway and prevent hypotension and hypoxia. Well, so why rehabilitation? It's because the survivors experience a substantial burden of physical, psychiatric, emotional, and cognitive disabilities which disrupt the lives of individuals and their families and pose a huge cost to the society. And because of these long-term repercussions of traumatic brain injury, we need rehabilitation, which can be neurodegenerative disorders like Parkinson's, dementia, or ALS, cognitive decline, stroke, post-traumatic epilepsy, schizophrenia, and bipolar disorders and depression, anxiety. So the goals include to normalize a patient's abnormal tone and increase amount of voluntary movement and increase responsiveness to sensory stimulation. The short-term goals include increased patient level of awareness and decrease extensor tones. So it is usually a multidisciplinary approach, and it consists of a team of neurosurgeons, psychiatrists, clinical psychologists, physiotherapists, occupational therapists, and social workers. And the rehabilitation includes restitutional rehabilitation, compensatory rehabilitation, and adaptive rehabilitation. In acute phase, this is what we usually practice. I mean, just proper head and neck position, seizure prophylaxis, tracheostomy care, bladder care, bedsore care, and good positioning in bed and wheelchair. And these are the domains of rehabilitation we usually focus on, which includes physical, behavioral, cognitive, emotional, personal, and environmental. In the want of time, I'll not go into the details. So a main thing is to teach the patient and their family self-care tasks and support the patient's family as they prepare for discharge. And obviously, as the didactic dictate goes, prevention is better than cure. So there are certain strategies which we should, which include primary and secondary. The primary directed at the prevention of injury occurrence, and the secondary aims to reduce the occurrence of TBI or limit its severity. And these are certain preventive measures which include buckling up of every ride, not driving under the influence of alcohol or drugs, and the children should be restricted in the back seats. A helmet should be worn, and for the older individuals, they should be regularly evaluated. Their medication should be evaluated, and one should try and not drive in speed. And most importantly, awareness should be built through print and social media and electronic media, and with educational camps and programs like this. Thank you.
I think yes, covered everything regarding the head injury in a very short and sweet manner. I don't know whether it is a head injury patient. I don't think has come here. Yes, we would have. Okay. 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 So we have just 5 minutes. No. as Dr. Kevin has explained almost everything, I would just like to add that head injury, the best treatment, as I said, is prevention. Okay, once a head injury, we don't mean head injury means just some injury to head. It is actually an injury to the brain. When we define head injury patient, it's a brain injury. And brain injury, as you know, it's almost a permanent injury. And if you recover from it, you are lucky. Most of the times, if severe head injuries and even moderate head injuries, people don't recover fully and they remain with some disability. And this is where our neuro rehab and all these treatments come into the picture. In even neuropsychological problems are quite a lot. So as he rightly showed, all disciplines are involved in managing a head injury patient. And as all other neurological disease, this is actually a real socio-economic problem for the country, because it's a real burden. As you said, in other cases, you lose the income, plus the family has a burden of managing you if you are not able to do the work. So ideally, everybody should see to it, whoever is driving two-wheelers, that they should not sit on the vehicle without a helmet, because that is one thing which will prevent all this. It's a preventable thing, that head injury, because we have had many patients with fractures and all this thing, but they were wearing helmet, nothing happened. However, those people who were not wearing helmets with just a minor fall also have got severe disabilities and all. So that's what I would like to say, that we should be careful in the when children are driving all these two-wheelers and all, because they usually don't try to wear. Thank you.
Thank you.
Thank you, Dr. Palande sir and Dr. Kevin for this. So now we move on to the next group, that is the dementia, and we have Dr. Urvashi Shah and Dr. Vidya Shenoy for this discussion. Over to you, ma'am.
Thank you very much for this opportunity. India is right now undergoing an economic and demographic transition. We know that. So economically, as we are moving from developing to developed status, what is happening is health services are improving. And we no longer have that level of mortality, but we are ending up with a lot of morbidity. So this is becoming a big issue. The second thing I want to point out is that when we talk about a demographic transition, currently India has the advantage of having a young population. So we say we have one of the youngest populations in the world. But if we look at the statistics, what we are seeing in terms of the elderly, from the census and from the other data, we find that it was the elderly population was 5.6% in 1961, 8.61% in 2011, 10.1% in 2021, and estimated to be 13.1% in 2031 and 16.1% in 2050. We are a population of 1.4 billion people, and these estimates can tell you the millions and millions of elderly that we'll be having on our hand with no proper planning or understanding of how we will deal with this. And a large proportion will be having dementia. So that is just to put out the facts that we're dealing with a huge epidemic which is coming into our lives, and we are very ill prepared for it. Coming back to dementia in terms of experience, what we see on the ground is that when we look at dementia, it's an umbrella term which incorporates cognitive changes, impairments in cognition, in emotions, in behavior. Now, there are three phases that I like to think of dementia in terms of public policy and other things. The first level is that when you think of dementia in the very first phase, that's diagnosis. Now, when we think of diagnosis, because dementia is a continuum from normal aging. So you have normal aging and you're losing cognitive function, then you have a mild cognitive impairment, and then you go on to have the dementia. So because it's a continuum, very often it is missed in the early stage as a part of normal aging changes. Particularly in India, I'd like to point out that we have a lot of understanding now, and we see this in research also, that there is this culture of care and respect for the elders. So when there are changes in the elders coming, cognitive changes are happening, people are becoming forgetful or behaviors are changing. As families, we don't bring it out of that culture of respect. That, oh, it's part of normal aging. So why should we take them for a diagnosis? And even when we say that there is a diagnosis, in our consulting rooms, we find that there is a stigma attached to saying, my father has got dementia or my mother has dementia. I've had fights in the clinic between the daughter-in-law and the son, where the daughter-in-law is saying, I can see clear changes in the person, in the mother-in-law, and the son is saying, I don't think anything is wrong with my mother. So we have a real cultural challenge of getting diagnosis. And that's why if we look at the epidemiology of the prevalence of dementia in the country from the various studies, you'll find different statistics available. The second challenge we have in terms of diagnosis and early detection is our tools, cognitive evaluation tools. When we look at a large population living in rural India, these tools that we have to evaluate and say a person has a cognitive deficit are not adequate. We have a floor effect on our test, we are not able to diagnose. So two things very quickly, early intervention if we want to do, if we want to look at pharmacotherapy in the early stages to at least slow down the process, we need capacity building and good diagnostic tools. We need to understand how to detect it in rural populations. We need to create huge awareness in our public about the differences between normal aging changes and what is the beginning of dementia. The second phase in dementia, when it becomes evident to some extent and people are coming to us with the diagnosis, is where the behavioral, emotional changes start happening. So it's not only cognitive, now they are really behaving differently. And the burden starts on the family. So the second issue is the caretaker, caregiver burden that is there. It's a huge socioeconomic burden because the caregivers have to give up their jobs, start looking. We again have a culture in India where we look after our elderly. We are not putting them away in the homes. The whole care comes on the patient's families. And here I think the way forward is telecounseling. We can't reach out to these people. We need to support them with capacity building of how to manage their elders at home. So telecounseling, psychoeducation through telecounseling would possibly be the way forward. And the very third phase where the person has advanced now and is almost bedridden and is not able to function, there comes the role of professional caretakers, attendants, who will be looking after that person. And the families need guidance about the resources for such kind of attendance or professional capacity building of caretakers, professional caretakers. It doesn't exist. Families don't know how to get these attendants who are trained very well on the ground. So we need a lot of work over there to build up that workforce of young professionals, caretakers, who will take care of the elders in the advanced stages if we are keeping them at home. And now, of course, when we're talking about this period, it's very important for dementia because the United Nations has declared 2021 to 2030 as the decade of healthy aging. So we talk about prevention, we're talking about what we do with dementia, but I think a lot, see vascular, in India, we're not seeing that much Alzheimer's as we're seeing vascular dementia. We're seeing mixed dementias. So a lot of this is preventable. And this era, 10 years we have, and India is a signatory. Our health minister on October 1st inaugurated LASI study, which is a longitudinal study for aging in India. So we need to collaborate with our government. They're open now. This is our decade. This is our opportunity to create awareness about healthy aging. And finally, you said to talk about ambassadors. I think we have some amazing ambassadors in our countries like Amitabh Bachchan, who at 80 is doing so much work. We have sportsmen who are at the older age and doing it. So their life stories of centenarians who have survived and what is it that caused and brought about their healthy aging. So these are all the kind of strategies that we can use, but it's high time we wake up because there's a big epidemic coming. Over to you, Vidya, about the practical aspects.
Thank you, Urvashi. Just to give the figures, a few years ago, we were told that there's an estimate of doubling of figures to 14,000 by 2050. The figures are horrendous as we see today that we have 8.8 million people affected or living with dementia. So I think it's a big dragon we have around the corner, and it's time we tame the dragon or manage the social problem. Coming to rehab, neuro rehab, for me, it's a different thing. Thanks, Urvashi, you spoke very well about, the actual practicalities also that gave a backup for me to continue from. So rehab for me is R, that's reactivating and restoring the earlier life that people lived with. E is for dealing with them with empathy. H is a holistic plan where you're sensitive to people as they are and putting yourself in their shoes so it's easier to handle them. A is making them aware of what a good quality of life is and there is hope. So A is for awareness. So we as integrative therapists would make this accessible and affordable, for which of course we need policy making, where the government will also come in and hold our hands because they are the people who give the funds. And B is believing in oneself as a therapist, that you can make your persons believe that the quality of life and well-being is there. So I think it's a bond between the therapist and the cared for or the person living with any disorder, that we build a bridge, we bridge the gap, or we build a strong bond which develops over time. So what are the therapies that we give? They're called non-format and complementary therapies, which are of two types. One is indoor, which includes games, craft, singing, painting, or little things like dance and movement or mudras, whatever you do at home without disturbing them. Because we must remember that most people living with dementia over the age of 65, though we do have young onset dementia today, and outdoor, that would include taking them for a walk, so long as they're not very fragile and have a tendency to fall. Take them to the seaside, let them sit on the bench in the park, let them see children playing, let them touch pets if they're not scared of or they don't have asthmatic problems, petting cats and dogs. So these are the outdoor. You can also have reminiscence therapy. Who doesn't like to go along memory lane, going, looking at the pictures in an album, seeing how nice it was to have parents spoil us, and today we are spoiling our children. Reminiscence therapy, pet therapy, doll therapy, lots of things. If you're creative, you can start. So that is indoor and outdoor. How do we implement them? Through individual and group. Individual is person-centered, where you are playing upon their likes and clearing the deficits. Group is making them continue interest and be favorable to their better quality of life and well-being. So what I want to tell you is that we have a center, Smriti Vishwam, Universe of Memory in Mumbai. Always welcome to call. If you want to volunteer, we are there. And remember, purple is the sign. So we invite even ambassadors or volunteers to our Purple Citizens Brigade. Thank you. So now we have spinal cord injury. I call upon Dr. Anurag Sharma and again Dr. Deepak Palande to take over the session.
Well, good morning. So, Sir has actually already covered the part in the brain part, which is important in the spinal injury part as well. The difference in other diseases as compared to the spinal cord injury and the traumatic brain injury is that rest other of the disease, may you win the lottery, right? It happens and it happens suddenly. These are the things you actually pick up, we take. We come from a society of gaadi to bhai chalayega, that attitude that after getting drunk, having this thing, and the people, unfortunately, people or the friends or other people who are there with them, they do not refuse that we are not going to sit in a vehicle driven by a person who is having this. And that on the top of a country with 1.4 billion people and less than 2% of GDP put in this thing, we need these forums. Because otherwise, no one is going to hear, no one is going to listen. Unless we create that voice, what Dr. Nirmal told, but that we have to create a voice. Unless we create that voice, it's not going to happen. So we have to have this forum. We have to be more vociferous and bring it on to so that people are there to change the way they look towards it. Brain injury and spine injury, unfortunately, again, the outcome actually is decided at the point point of impact. The moment it happened, the amount of injury is going to happen. It can be a part of it. A lot of part of it, in fact, can come because, you know, once you get into an injury, we get into a mode of where, first of all, it comes into denial. And then, you know, you start cursing the whole family, society, that why it happened with me and whether it was responsible or not. And then you become recluse. You think even then that if you have to work, you know, hard, nothing is going to change because I'm going to remain paraplegic, right? Now, that is where the rehab has to work. That is where, because same injury, I can show you many people who have done extremely well and they're living their life despite being paraplegic. They understood that this is the limitation, but, you know, they took the opportunity to put their more stronger perspective. And I know people who are there in the bed and they just don't want to get this thing, sometimes forcing people. So the choice is there. But we have to understand that this is something which was preventive, right? Most of the cases it was preventive, and unless, you know, you're sitting somewhere and a vehicle rams on you, then it's a different issue. But in 90% of cases, it does not happen. 90% of the patient who come with, they were on bike, they were sitting in car, they were involved in the accident. I mean, it can be because of somebody else's fault, but then that's how it is, you know. But once it is done, the rehabilitation part becomes stronger. And for me, rehabilitation part, the moment the immediate treatment part is done, the moment we have fixed the spine, and everybody does that job very nicely. The difference is going to be that how from that point onwards, the neuro rehab to take over. And then it is the mental, it is the physical, it is all the activity. So that's how it is. And sir, would like to add on?
I think Anurag rightly said that head injury and spine injury sometimes occur together also, especially with two-wheelers. But the difference between pure head injury and pure spinal injury is that in a spinal cord injury, the brain is intact and the patient is feeling everything and realizing all these things. Again, there are two aspects of the spinal cord injury. One is in the cervical spine, the connection between the whole body and the brain is broken. The whole body is paralyzed and you can't do anything. In a little lower level injury where you get only paraplegia, at least your hands to support you. And so the quality of life is slightly better for people with paraplegics than with quadriplegics. And today the main problem of management is for the quadriplegics, because this is very, very difficult to handle these people who realize everything but just can't do anything. Everything they are dependent. So as far as the disabilities is concerned, head injury and spine injury, the trauma are the only preventable causes of the disabilities which we have, and which is the maximum actually. They are the suppliers for all the rehabilitation people, the head injuries and trauma. Whereas these other things like cerebral palsy or maybe even stroke, you can't prevent it just by doing. Of course, they say stroke can be by a diet and all these things, but then that is a different issue. But all these other things like dementia also, you can't help or prevent it. Like how you can prevent a head injury or you can prevent a spinal cord injury by following certain precautions. Spinal cord injury mostly in falls. If you see you must have all realized who working in our trauma care centers, children, they dive in the pool and they develop a spinal cord cervical fracture because the pools are very shallow and they dive it and they bring the child with quadriplegia. So these are all preventable things. It is written on the pool, the depth and all these things, but still these things are happening. So parents also have to be careful about managing their children when they are doing all these activities, because once it happens in the central nervous system, there is no as a way of regenerating the things. We can give neuro rehab, it can improve to some extent, but it doesn't come back to its original normal state. So there is almost permanent disability there, partial maybe sometimes total, then we can't do anything. So I think that is the take home point, is that as far as spinal cord injuries and head injuries are concerned, it is the prevention is the only method of treating. Thank you.
Thank you, sir, and thank you, Dr. Anurag. Dr. Anurag is from a defense background. He has served with the Indian Army, and he is the longest-serving neurosurgeon at the Antarctica also. So, and I would like to highlight here, since he has got the defense background, and he's my ex-colleague, bullet injuries. We have seen a lot of bullet injuries also coming up. War is really a crime. So that is against humanity. So we get a lot of patients who have just a shrapnel injury or to the spine. So it's a devastating thing for the young people. And you can't do much for these guys. They are just having facility, bladder symptoms, just living with that the whole life. So it's really troublesome to see. So I will thank you, Dr. Anurag. Thank you, sir. I would like to now call upon Dr. Neha, who's gonna have us have experienced some vertiginous feelings. So talk about chakkar ka chakkar.
Yeah, good morning, everyone. And at the outset, I would like to first thank Dr. Nirmal Surya sir, IFNR, and Vidya Shonai ma'am to bring in the subject of vertigo for the very first time and inviting the ENT fraternity with open arms and including us also under the neuro rehabilitation program. I'm Dr. Neha Srivastava. I'm a consultant neuro-otologist, vertigo and ENT specialist, and I'm also the director for the American Institute of Balance India. So basically, the idea was to showcase that vertigo is basically a multidimensional challenge. The patient keeps on moving around to different specialties, right from ENT, from orthopedics to neurologists, psychiatrists, counselings, and in fact to the physician, because of the lack of awareness among the doctors, among the patients about the subject of neuro-otology. So let us start first about vertigo. So vertigo is basically a subjective sense of motion. So anything which is rotatory spinning, tilting, or if there is an imbalance or there is a sway, they come under categorize it as the vertigo. Challenges which are faced by patients. So this is from the patient perspective. It's a debilitating condition. There is a loss of morale. The patient becomes physically handicapped. There's a lot of psychological state involved, because when the patient is getting up, lying down, trying to bend, trying to do any kind of routine activity, they are not able to make up because of that. There is an emotional dependency on someone else, but at the end, the caretaker also gives up, saying that nothing can be done, and they label it as psychogenic at the end, giving them antidepressants. There is always medicine dependent. I have many cases wherein the patient gets up in the morning, have their beta histone or prochlorperazine just to start off their day, and at the end they have maybe any kind of short-acting benzodiazepine to delay the short alley of anxiety amongst them. The high cost of diagnosis, because the patient has to run from one clinic to the other clinic to the third clinic and then go and ultimately land up in city MRI. And of course, nowadays with the vestibular evaluation coming into the picture, that's also a high cost testing because of the equipment that's based on virtual reality. So that all is an additional financial loss, and the patient doesn't earn also in their normal livelihood. So that is another issue which they face. And of course, vertigo is mainly an underdiagnosed condition. The lack of awareness among the healthcare professionals further add to the dilemma. Then there's a confusion happening with the spinning and spinning going around. So what is a medical dilemma that what we face? So what we face is that we don't know it's whether it's treatable or lifelong. So let me answer your question now, that 80% of the cases can be treated of vertigo. Is there a relapse? Yes, when we deal basically with the migraine-induced vertigo and basically we're treating with Meniere's disease, there are the conditions wherein there can be a relapse. Cervical spondylitis, let me make it very open and to the public forum also, that cervical spondylitis is not the cause of vertigo. It is benign paroxysmal positional vertigo. There is nothing known as cervical spondylitis-induced vertigo. If you talk about cervicogenic vertigo, then we go on the lines of VPI, that is vertebrovascular insufficiency. So there is nothing known as cervical vertigo. There is a gap in, everybody has gap. We all are sitting, we doctors have a very bad posture. We also have gap, but we are not among the vertigo patients. So it's not cervical spondylitis because every patient entering in is coming with an excess cervical spine epilateral. The next is medicines. There is a cure for vertigo, which I'll brief in my other 2 slides. Non-specific exercises, just going around with doing head and neck exercises, Cowtown, Cooksey regimens, or doing something which a major pharma company is giving you as a leaflet is not a treatment for vertigo. So vertigo is a wide spectrum. I divide vertigo into 6 categories as per my understanding at this particular age. So coming from the central background, I will categorize it as the brain, spine, and foot involvement. Peripheral will be because of eyes and ears. Systemic will be anything from anemia to dehydration to blood pressure to hypothyroidism to diabetes. Psychogenic will be maybe a bipolar depression, schizophrenia, or a depression or an anxiety. Autoimmune conditions like autoimmune ear diseases, SLEs, they are also a part of the process, and drug-induced conditions. Many drug-induced conditions, especially the anti-epileptic drugs, they can also induce ataxia. So these things have to be created an awareness, or a long doses or a high dose of medication of anti-vertigo for a very long time can also lead you to vestibulopathys. Management. So basically, how do we deal with these cases? So we deal with an history, with a clinical evaluation, with an audiological and vestibular evaluations, radiological and pathological investigation, symptomatic relief. And the major lines of treatment for vertigo is a Canalith repositioning maneuver. Also, you must be very acquainted with Epley's maneuver. But let me specify that benign paroxysmal positional vertigo has 14 types and 12 different maneuvers to go around with this. So it's not only the medicines, it is the maneuvers and the rehab techniques that we use. And the last is the vestibular rehabilitation techniques, which starts from adaptation, habituation, and substitution exercises along with the proprioceptive mechanisms. Now, the vertigo treatment aims and option. The vertigo treatment aim is to reduce the elimination of the hallucination of the motion, to reduce or eliminate the neurovegetative or the psychoaffective, and to enhance the vestibular compensation among the patient. The range of treatments may start from drug therapy to physical therapy to cognitive behavioral therapy, and very rarely we go into the surgical management when the medical management fails. So thank you. We at AIB India, American Institute of Paris India, which is a Florida-based firm, we'd like to support the doctors and also support the patients and build in a vertigo support group to take it from here, and we change the face of vertigo in the coming generation so that everybody has a great awareness of the knowledge and the subject, and the patients get completely cured by this. I would like to invite Jaya ma'am. She has been, her relative had vertigo. She would like to speak 2 lines about what they faced during this condition.
सभी को नमस्ते, मैं जया राज हूँ। सिर्फ 2 मिनट आपका कीमती समय लेना चाहती हूँ। मुझे मेरे भाई के बारे में बात करना था। मेरे भाई को वर्टिगो हुआ करके इसके बारे में हमें कुछ भी नहीं पता था। वो काफी मतलब सफर कर रहा था। इतना हो रहा था कि घर के लोग सभी परेशान हो गए थे, क्या हो रहा है इसे पता नहीं। उसके जॉब पे जा नहीं पा रहा था, गाड़ी नहीं चला रहा था, खाने पीने की दिक्कत हो रही थी। जब भी लेटा रहता था घर पे तो ऐसा कहता था ये सारा जो घर है ना मेरे ऊपर गिर जाएगा, मुझे कुछ हो रहा है, ऐसा बहुत उसको तकलीफें हो रही थी। फिर मेरे मम्मी पापा है वो जो थोड़ा सा उनको लगा कुछ मन्नत कर लेंगे, मंदिर चले जाएंगे, वहां पर हो जाएगा ठीक, लेकिन कहीं पे कुछ नहीं हो पाया। उसके बाद में फिर मैंने सोचा कि मैं क्या करूं, मुझे समझ में नहीं आ रहा है। काफी हम लोग परेशान थे, हमारे फैमिली पूरी परेशान थी उसके पीछे। फिर मैंने क्या किया, डॉक्टर नेहा मैम का हमको एड्रेस मिला, उनके बारे में हमको पता चला कि ये वर्टिगो के लिए देखते हैं। लेकिन वर्टिगो जब तक पता ही नहीं था कि क्या है करके, ऐसे लग रहा था कि कुछ उसको हो गया है। फिर हम लोग उधर उनके पास में आए, वो पालघर से है, पालघर से यहाँ पर बुलाया गया उसको। और फिर उसके बाद में डॉक्टर नेहा को दिखाने के बाद में उनका सारा ट्रीटमेंट, जो एक्सरसाइज, 2 दवाइयाँ है, वो सारी ट्रीटमेंट उन्होंने बहुत सही तरीके से किया। के बाद में वो बहुत अच्छा हो गया है। अभी कोई भी दिक्कत नहीं है, कोई प्रॉब्लम्स नहीं है। अभी खुद गाड़ी चला के जाता है, अपने फैमिली को वगैरह सब अच्छे से देखता है। आप लोग को बहुत बहुत धन्यवाद करती हूँ। आपने 2 मिनट मेरे को बोलने के लिए, बात करने के लिए समय दिया है, इसके लिए बहुत बहुत धन्यवाद। और लास्ट में एक ही शब्द बोलना चाहती हूँ कि वर्टिगो के लिए अगर हमें सही मार्ग मिल जाता है तो पेशेंट को कोई भी दिक्कत नहीं है। वर्टिगो अपने को है ही नहीं, बस हम लोग उसमें से निकल गए। बहुत बहुत धन्यवाद।
एंड मुझे बस एक आखिरी बात कहनी है कि चक्कर का चक्कर रिजॉल्व हो जाएगा, क्योंकि डर के आगे जीत है. सो बेसिकली अगर डर खत्म हो जाए तो चक्कर भी ठीक हो जाएगा. ट्रीटमेंट इज देयर. थैंक यू वेरी मच. थैंक यू एवरीवन ऑन दिस फोरम.
Thank you, Dr. Neha. Now I call upon the next group, that is the aphasia. So to talk on this, we have Dr. Apurva Puranik with his vast experience of more than 4 decades. And we have Sonal Chitnis with us, who has got a lot of experience with the rehabilitation and assessment. Yeah.
Good morning. So I'm privileged to represent Indian Federation of Neuro Rehabilitation, Indian Academy of Neurology, Aphasia Expert Group, and a core member of and a coordinator of SIG, a special interest group on aphasiology from Indian Speech and Language Association. And I would like to thank Dr. Nirmal Surya sir and all the team member of IFNR for giving me opportunity to advocate, educate on aphasia and neurocommunication disorders. Aphasia क्या होता है? वाचाघात या वाचा ह्रास या लकवा मारने के बाद में जब लोग बोल नहीं पाते हैं, तो इसके अलग अलग causes होते हैं. I will try to speak in Hindi and English both, since it is a public forum. I would make it simple. So aphasia, not able to speak, understand, read, write, calculate, due to any acquired, that means someone has a brain injury. So earlier the person might or should have the language properly acquired. जो पहले कुछ साल तक बात कर पाते थे, समझ पाते थे, it could be a child जिसको stroke हुआ है, head injury हुई है, या brain tumor हुआ है. It could be an adult, it could be an elderly who has a stroke or a brain injury, a brain tumor, or a dementia of Alzheimer's or frontotemporal dementia or any other form which is harming, which is somewhere assaulting, which is somewhere harming your language pathways, their circuitries and functionalities. So जहाँ पर लोगों को जहाँ एक्वायर्ड न्यूरोलॉजिकल डिसऑर्डर हुआ है, ब्रेन में विकार हुआ है, तब मस्तिष्क में कुछ चोट आई है, जब वो बात नहीं कर पाते या समझ नहीं पाते, लिखना, पढ़ना, कैलकुलेट करना, इससे कम्युनिकेशन में ब्रेकडाउन होता है. सो समवन हु कांट कम्युनिकेट एज एफिशिएंटली टू बी अ स्टूडेंट, टू बी अ टीचर, टू बी अ homemaker, and we all have to communicate. That is aphasia, and aphasia can lead to real difficulty and impairment in quality of life. And there are many causes of aphasia we know. And how do we assess? So we ask someone, can you tell me your name? Can you tell me about yourself? Can you name some simple pictures you can ask? कि ये क्या है? So 5 simple cards of everyday pictures are object naming, and you can ask, ये क्या कर रहे हैं? ये क्या कर रहा है? इस picture में क्या कर रहे हैं? That is object and verb naming. Also, we have a simple picture to describe where we ask the person to narrate. इसमें क्या दिख रहा है आपको? जब व्यक्ति समझ नहीं पाता है या समझ पाता है लेकिन बोल नहीं पाता है, शब्दों में, वाक्य में, और डेयरी मरे की चीजों में हम जस्ट वाक्य में नहीं बोलते, हम बहुत सारी चीजें पूछते हैं, बताते हैं. We need to express our desires, needs, so that can get really impaired. Now with the occupational needs, where you are engineer, doctor, or you are a teacher, you are a student, if you are not able to read, understand to that level of intellectual needs, aphasia can be debilitating. So one needs to advocate, assess, and rehabilitate acute care setting where the person has a stroke, and his communication at bedside, at hospital, when the person is getting discharged, how he or she has to receive adequate rehabilitation. And we also have a tele-assessment, tele-rehabilitation, technology, apps available for aphasia. So in India, we all are bilinguals. मैं मराठी हूँ, मैं हिंदी, इंग्लिश, तेलुगु बात कर पाती हूँ, थोड़ा तमिल समझ पाती हूँ, but I should be able to understand, read, write, communicate in the language of proficiency at my home, at my work front, at my neighborhood, if I have migrated to some country or some place. So we require a bilingual rehabilitation. Thank you.
So taking the cue forward, I won't be speaking on aphasia anymore. Sonal has already briefed. What I will take that all of us agree that the Indian Federation of Neurological Association must come, and it will come. It would be an Indian Federation of patient support groups dedicated to different neurological disorders. And it would be in parallel with the development of the white paper, where the input would be received from various neurological associations. And we are part of the historical process. We are lucky to be a part of this historical process where Indian Federation of Neurological Associations and the parallel white paper are in the process, and we are part of that team. There are many paths. Each neurological disability has its own peculiarities, and yet there are many common grounds. So there are many things which are common. From that common ground, I want to suggest a few things which can be applicable to all neurological associations, all neurological disabilities. Number one, there are difficulties in creating patient support groups. The number of diseases and the number of localities where such groups must be working is very small for a country like India. I have been trying hard for many years to create patient support group for aphasia at Indore and other cities, but I have not been very successful. Wherever there are some groups, some of them are doing good work and some of them are not doing that good work. So there is a scope for improvement. So it is my suggestion. We can have an annual workshop on how to organize patient support group, in which we will invite representatives from each patient support group in a close brainstorming session of 1 or 2 days, which can be held on the sidelines of IFNR conference or maybe as a midterm meeting. So that the president and secretaries and office bearers of different patient support groups will share their experiences and will learn from leaders what are the leadership skills, how to get the membership drive, how to groom the leadership, how to retain the membership, what type of activities can be done. So one group is doing one sort of activities, another group. So each would be a learning experience for all of us. That should be one annual event of workshop, how to organize and how to sustain and how to improve the activities of patient support group. That should be one fixture. All these groups should be taught how to create the awareness about particularly the rare diseases. Epilepsy is a common disease and people are aware about epilepsy and stroke, but much less number of people are aware about aphasia or ALS or more rare diseases. So how to create, what should be the strategies, like we had yesterday, the wonderful input by the MBA students, what sort of programs can be done, what should be the strategies for education, what should be the strategies for advocacy, and in advocacy, in white paper, what should be our priorities to the government of India. I think our priority or our highest level demand in our white paper with the government of India and with the state governments should be to have district level services for all neuro disabilities. Every district hospital in government sector, that should be our focus, our thrust area of advocacy. Each center at district hospital should have OT, PT, clinical psychology, SLP, and not only the personnel, but the supporting staff, standard operating procedure, the guidelines, the training manual, the education manual, the data recording, the research. We will give all this detail in our white paper, that each district level And there can be 50-50. Government of India is doing this module, 50% budget by the government of India and 50% if the state government is contributing. So such proposals we can give. That was my second suggestion for the white paper. The third is that we should encourage life participation and employment. Our persons with disabilities are secluded, they are depressed, they are cut off from the life. So as we are talking of life participation approach in aphasia, the same principle is applicable to all disabilities. And the fourth is employment. The re-employment can be to a lower level, may not be as good as the earlier job. And we should strive in our advocacy efforts for creation of sheltered workshops at the district level in the public sector or maybe in public-private partnership. Our persons with Parkinsonism or cerebral palsy or spinal cord injury, paraplegia should get a job. And those jobs can be provided in sheltered workshop. And we should have advocacy to potential employers all over the country. Look, these are the rights of these are the capabilities of our persons with disability. They are employable. So that motivation should come from us. Thank you.
Thank you, sir.
This is a very special session because we have two Golden Light awardees with us for the session. That's Divya Sharma and Nazia Ansari. And we have doctors Jayanti Mani and Purnima Gauri.
Hello. Very good morning, everyone. Thank you so much for giving an opportunity to participate in this conference. My name is Nazia Ansari, and I'm a person with epilepsy since year 2006. And once the epilepsy came in my life, it brought so many difficulties during my education, my studies, in my employment, and further for marriage and other multiple things came along with the epilepsy. When I started, my medication from Dr. Nirmal Surya sir, I got to know about epilepsy more, and then my life changed because that difficulties got converted into an opportunity, and I started working as a social worker in Epilepsy Foundation, and post that, for doing that work, which was my responsibility, I believe, being a person with epilepsy, to educate other people as well. And I got a Golden Light Award for year 2022. And this was not enough. Then apart from that, I got an opportunity from IBE. And now I am a community council member of IBE, which is International Bureau of Epilepsy. So I am very thankful to Dr. Nirmal Surya sir to give me an exposure to all these things and help me out throughout my journey of being a patient to now being a successful patient. And I'm very happy to be an epileptic because it gave me lots of exposure as well. So I am not unhappy, but I'm happy because I got an exposure. I got successful because of epilepsy. I take it in a positive way. Thank you.
Hello everyone, my name is Divyanshini Sharma. I'm 19 years old, of course, young from everyone, yeah. I'm an yoga instructor at Epilepsy Foundation and also a student. I'm studying in TY BCom. It's my last year of graduation. I'm a person with epilepsy since 2013 when I was in 6th standard. तो दैट टाइम जब मैं स्कूल जाती थी तो दे टेक मी आउट फ्रॉम स्कूल कि अरे ये कैसा बीमारी है, इनको हटाओ, वैसे नॉर्मल स्टूडेंट के साथ मत रहने दो. देन आफ्टर 3 months और 6 months मैंने फिर से वो स्कूल ज्वाइन किया. मुझे डॉक्टर निर्मल सूर्या सर के बारे में मालूम पड़ा, एपिलेप्सी फाउंडेशन के बारे में मालूम पड़ा, तो आई हैव गॉन देयर, आई हैव स्टार्टेड माय ट्रीटमेंट देयर. तो फिर मैं उसी स्कूल में एकदम तान से गई कि हाँ मेरा एडमिशन अभी फिर से यही स्कूल में मैं लूंगी. मैंने जिद किया वो स्कूल में जाने की. people here talks about epilepsy, not only epilepsy, सब disease के बारे में बात करते हैं, disease से कैसे fight करना है, disease को कैसे cure करना है. But I am different from them. मैं खुश हूँ कि मुझे epilepsy है. I'm very happy that I'm glad I'm having epilepsy. I'm a person with epilepsy. Because अगर मुझे epilepsy नहीं होता तो I won't be able to like इतनी famous नहीं होती मैं योगा इंस्ट्रक्टर नहीं होती, मैं आज यहाँ पे खड़े होके आप लोग के सामने बोल नहीं रही होती, मुझे इतने सारे अपॉर्चुनिटीज नहीं मिलते. एंड आई एम ऑल्सो एन गोल्डन लाइट अवार्डी. यू कैन सी माई अवार्ड हियर. सो थैंक यू.
Yeah, thank you. I think this speaks volumes about what can be done. I think Dr. Surya, all credit to you for, having inspired so many people like this. So I think, can we have the next slide? So here we are to talk about epilepsy and from a public health perspective. Now, when the medical aspects are all known to all of us, it's about, having fits or seizures, and it starts very early. It's a long journey that people have to live. They have to take medications for long periods, and it has to be uninterrupted medications. But this, the doctor gives you all this advice, and, out of the clinic you go, and then you have to face this big bad world. So there is a lot of anxiety, uncertainty about seizures. You may fall and hurt yourself. So all of this is something looming large in somebody's mind with epilepsy. So living in society with epilepsy is a completely different ballgame. There is this whole huge aspect about stigma, which you're going to talk about again. And that leads to a lot of isolation for people when they are faced with the problem. It's right from, as we just heard from stories from our young warriors, whether it's school, whether it's friends, work, marriage, all aspects of our life. And that itself takes a toll on mental health. There is so much of worry, should I inform people about my epilepsy or not? So all of this is a big problem. And at our own levels, as doctors, we have recognized some bit of this, and our very visionary seniors did come up with this idea of having an association for patients. And we have so many of these now. The Indian Epilepsy Association, of course, is at a national level. It has multiple chapters, and one of them is Samman, which I represent. But apart from that, like the foundation, Epilepsy Foundation of Dr. Surya, which is doing phenomenal work, then the Sanvedana Foundation, which is in Pune, that works for marriage for people with epilepsy. And we also have Purnima here. She, at her own level, is doing advocacy for people with epilepsy, trying to kind of integrate them into normal life. So all of this is required to be done, but these are being done in small pockets. And what we are emphasizing is more awareness, more patient support, and also to reach medical care for people with epilepsy. I think that is a big, big, big challenge. So when we look at it from I'm showing you what we do at Samman. We try to, do these activities for awareness. You will be surprised to know that it's not general public alone, but even paramedical workers, nursing staff, even they, and even doctors at the primary healthcare center don't know what to do if someone has a seizure. So there is a lot of gap, and this is a simple thing that they need to know, but it's not there. So we need to look at doing all this. Then, digital media is now a big force that we can use to spread awareness, share people's lives. Like, people like Nazia need to make their lives, and Divya need to make their lives more, public, so that other people get inspired to do this. Then we need to have more one-on-one counseling for people sometimes. Then personal counseling, and, all kinds of rural camps to make medications available for people. So these are the things we do in Samman, and sure, so many other foundations, and we already know how Epilepsy Foundation does so much of this. So when we look at it at a public health perspective, what is really necessary? One is mass awareness, I think at a very public level. Schools, colleges, paramedical professionals, police personnel, and even railway personnel need to know how to do this. And this can't be done at an individual level. It has to happen at a public level. In fact, I suggest it should be part of ACLS training, so that people who are taught about cardiac resuscitation should also know what is seizures all about. And in schools, all the comorbid issues need to be addressed, because now we talk about right to education. So mild things like attention deficit or slow learning should be addressed, because these are the issues that children face. even if their epilepsy is taken care. Medication supply. I think this is a big, big piece at the primary healthcare level. And seizure first aid. People should be aware. The primary healthcare worker should know what should be done if someone has a seizure. Another big area that we need work on is insurance for people with epilepsy. You all will be surprised to know, I don't know how many of you know, that if someone has epilepsy, not only for epilepsy, but all other medical conditions, they don't get any insurance. So this is really, really unfair to people with epilepsy. And there are some other issues like marriage and things, which I will ask Purnima to cover.
Just a minute more I'll be taking. So marriage, as Nazia herself had referred in her talk, and she is yet to reach that milestone. So yes, it is a big issue, and Yashoda Wakankar from Pune is working on that. Sorry. Yeah. So Samvedana Foundation has a separate marriage bureau for people with epilepsy, where one person with epilepsy is encouraged to marry another person with epilepsy. So there is a lot of empathy, understanding, and therefore they can manage it better. In the regular marriage bureaus, the people are discouraged from declaring about their epilepsy. And that has actually to stop. And we can do that only through our awareness models. Next slide. Another point I would like to make is geriatric epilepsy. After stroke and dementia, the third morbid neurological problem in geriatric population is that of the first seizure occurring at this. It could be either post-stroke, it could be something running along with dementia, or it could be occurring on its own as well. And they have a different clinical profile, and even clinicians need to be aware of it. Physicians need to be aware of it. These people have comorbidities. They have hypertension, diabetes, IHD, stroke, maybe an operated brain tumor. So they are already on a polypharmacy, and therefore choosing an anticonvulsant drug in these patient population is very different. And the side effect profile of drugs in these people is also different. Other topics, of course, epilepsy is a vast topic because writing a prescription takes hardly a minute, but the people are living their lives 24 hours. So there are so many psychosocial issues which we will discuss in the panel discussion. Thank you so much.
Thank you for your time. And really, thanks to this opportunity.
I can't thank you more. I think these people deserve a round of applause for a very good representation of a very pertinent and a very sensitive matter. So I would like to withhold proceedings for a time. Dr. Nirmal Surya wants to say something.
I don't much thought. I would just want few more patients who have come all the way. Nitin, Nikhil, and Mercy. Please come here. Mercy also. Huh? You see, there are a couple of things. Jayanti, where Jayanti is? Yeah. You know, I don't like this concept of marriage where you are asking an epilepsy patient to marry another epilepsy patient. I think this is completely wrong. This is an indiscrimination. And I think that's the reason this bureau will never be successful. Because you are discriminating an epilepsy patient separately and asking them to marry separately. If you ask them, nobody will like it. I give you an example. In last 5 years, at my center, I at least has 30 young girls got married. And got married to the normal person. In fact, 2 weeks ago, Meena has come. She has delivered a baby boy, healthy, 3.25 kg. She worked at my center for a few months before she got married. So I feel that as a neurologist, we should concentrate on getting the patient better, improve the quality of life of them, and ask them to get married to someone whom they can get married. The problem comes in female, we empower them. Now, if you can empower like these people, she is a bank manager, she's want to become a lawyer, then there is no problem. They will get married because somebody will like them and get married. This is what a neurologist and as a society, we should be working on. We should not encourage something which put a person down. We should encourage the people to lift them up further and feel that they are as normal as any other person. That's my message to all of you. Here is this gentleman. I think many of you know him, Nitin. Nitin and Nikhil are two brothers who have an epilepsy. His epilepsy is fairly well controlled. He gets once in 1 year or something, but he's okay. He does all activity. Nitin gets still 3 to 4 complex partial seizure every day. When he came to me, he was getting 7 to 8 generalized seizures. And in some of the seizure, he would run, remove his clothes, fight, don't allow anybody to touch. Am I right? And I have to admit him twice. But look at him. I appointed him in my center. I gave him a work. He makes this bag. These bags are made by him. He must have made more than 10,000 bags. And the bag which you have got, the kit of IFNR has been made by these two people. So 500 bags they are made in last 2 months. So now Nitin comes at 10:15 to my center, 10. If he comes little late, he gets firing from me, so he's scared. He travel in the bus from Volkeshwar alone. His brother doesn't come. He come himself. He does yoga for half an hour. Then he sit down and start making his back. He religiously make back. His seizures are down to 1 to 2 to 3. We all know that when he gets seizure, you probably would not even notice when he gets seizure. These are such subtle seizure. I put the camera, I catch him. So now look at his quality of life. He's working, he's earning, he's independent. Once in 2 months, instead of Volkeshwar, he goes to police station. Instead of Marine Line, sometime he gets down at Lohar Chal. That happened when he has got little complex partial seizure. But he manages to come in time, do the work. So that is what I'm saying. We really need to look at how best, because we don't have time to talk to the patient. That's where is the problem. And I think Apurva Puranik will agree with me, having worked in epilepsy. We need to see how best we can give them employment, encourage them, and they need to have faith on you. That whatever you are saying, it's a godly word to them. That's where their epilepsy automatically gets controlled. So this is not about epilepsy. This is about any neurological disorder. You need to give self-belief to the patient that look, you need to fight, you can do it, and if you fall, we are there to lift you. That's it. Do you have anything to say? Because I'm taking too much of their time. But I wanted a message to be given to them because I really feel that we need to improve upon these people, give them a normal life so that they can themselves fight with others, not you and me fighting for them. We should encourage them to fight themselves. So now they are fighting. They will encourage 20 more people to come forward. And look at the flower he has made. And whom you want to give?
These are the things we made in wastage, which wastage things we made at Epilepsy Foundation. And these big bags are made by me. But give it to Dr. Nirma Surya.
Thank you, sir, for the wonderful experience. I will call upon, I would like to call upon the next group for the cerebral palsy, Dr. Taral Nagda and the Gandhi family, for their representation and their deliberation on the topic.
Thank you, everyone. Vidya ma'am,
and Nirmal Surya sir, thank you for this opportunity. आरुष ट्रस्ट ये एनजीओ है, अगले पिछले 7 साल से ये सेरेब्रल पाल्सी, इंटेलेक्चुअल डिसेबिलिटी, ऑटिज्म के लिए काम कर रहे हैं। और आरुष ट्रस्ट इन सारे बच्चों के लिए अभी जो सर ने बोला कि डॉक्टर के पास पेरेंट्स से बोलने के लिए टाइम कम रहता है और सारी बात एक अपॉइंटमेंट में एक टाइम में नहीं बोल सकते, तो आरुष ट्रस्ट अभी ये काम कर रहा है, पेरेंट काउंसलिंग फॉर दिस पेरेंट्स। जब डॉक्टर के पास सेरेब्रल पाल्सी, इंटेलेक्चुअल डिसेबिलिटी, डाउन सिंड्रोम, ऑटिज्म के बच्चे आते हैं, तो आरुष ट्रस्ट पेरेंट काउंसलिंग करके प्रॉब्लम क्या है और कहाँ से हमको कहाँ जाना है, ऑटिज्म माने क्या है, सेरेब्रल पाल्सी क्या है, ऑपरेशंस, बोटॉक्स क्या है, करेक्टिव सर्जरी क्या है, ये पेरेंट को पहले बता देते तो पेरेंट प्रिपेयर रहते हैं और डॉक्टर को थोड़ा इजी हो जाता है पेरेंट के साथ बात करना। मैं वृषाली गंधे, मैं आरुष ट्रस्ट फाउंडर मेंबर हूँ, लेकिन उसके पहले एक सेरेब्रल पाल्सी बेटे की माँ हूँ और अभी ये मेरा बेटा 19 इयर्स ओल्ड है, फुल्ली इंडिपेंडेंट चाइल्ड है। और ये मैं ये बोलने के लिए अभी ये प्लेटफॉर्म का यूज कर रही हूँ, दोनों डॉक्टर्स अर्णव के यहाँ पे है, डॉक्टर तरल नागदा एंड डॉक्टर श्रेयस जागीरदार। सर ऑर्थोपेडिक सर्जन और ऑक्यूपेशनल थेरेपिस्ट डॉक्टर श्रेयस जागीरदार, उनकी वजह से ही इज नाउ इंडिपेंडेंट चाइल्ड। ये ट्रस्ट पहले यूडीआईडी के लिए काम करती है। यूडीआईडी अभी जो सेंट्रल गवर्नमेंट का डिसेबिलिटी सर्टिफिकेट है और वो सबके लिए मैंडेटरी हो रहा है, हो जाएगा, उसके हिसाब से ही सारे बेनिफिट्स और जो भी पेंशन्स है, इंश्योरेंस है, जो भी है वो यूडीआईडी के थ्रू मिलेंगे। ये यूडीआईडी का हम वो 13 डिजिट का जो कोड असाइन होता है तो वो हम करके देते हैं। यूडीआईडी कार्ड अभी सबके लिए, सब डिसेबिलिटीज के लिए मैंडेटरी और वो हम इन बच्चों का पहले करके देते। उसके बाद इन बच्चों का सेरेब्रल पाल्सी, इंटेलेक्चुअल डिसेबिलिटी जो भी है, उनका गार्डियनशिप लेना सबके लिए होना ही होना है, क्योंकि अगर बच्चा 18 साल का होता है तो वो अपने खुद के डिसीजंस नहीं ले पाता, किसी भी हिसाब से वो डिसीजन अगर नहीं ले पाता तो उसके बिहाफ में कोई डिसीजन लेने वाला चाहिए, इसलिए ये गार्डियनशिप हम करके देते हैं। गार्डियनशिप से बच्चों का जो भी आप जो भी है, आप उसके लिए कुछ रखना चाहते हैं, उसके लिए कुछ प्रॉपर्टीज है, कुछ उसका रिहैब करना है आगे का और कुछ पैसे का इंतजाम करना है, तो आपको गार्डियनशिप लेनी है और बच्चों का रिहैब आप कर सकते हैं। गार्डियनशिप के साथ साथ हम इन बच्चों का इन सिर्फ 4 कैटेगरीज का इंश्योरेंस अभी अवेलेबल है सेंट्रल गवर्नमेंट से, सेरेब्रल पाल्सी, इंटेलेक्चुअल डिसेबिलिटी, ऑटिज्म और मल्टीपल डिसेबिलिटी के लिए वो निरामय है और वो इंश्योरेंस हम बच्चों को पूरा करके देते हैं। यूडीआईडी कार्ड, बाद में इंश्योरेंस और बाद में गार्डियनशिप। ये इंश्योरेंस में उनके डेली ओपीडी चार्जेस है, मेडिसिन है, अल्टरनेटिव मेडिसिन है, करेक्टिव सर्जरीज है, ये सब ये 4 बच्चों के लिए अवेलेबल है जो अभी निरामय इंश्योरेंस का रेगुलर चलता है। लेकिन ये जो इंश्योरेंस हम लेते हैं बच्चों के लिए, तो अभी ये इंश्योरेंस का लिमिट बढ़ना चाहिए। एज अ पेरेंट, एज अ ऑर्गेनाइजेशन हमें जो लगता है कि थेरेपिस्ट का करेक्टिव सर्जरीज और जो भी उसका ओपीडीज है, मेडिसिन है, उसका जो खर्चा मिलता है निरामय से, वो बिल्कुल काफी नहीं है इन बच्चों के लिए। तो ये 1 लाख से 5 लाख तक होना चाहिए। और उसमें जो कैटेगरीज उनमें उन्होंने कुछ डिफाइन की है, करेक्टिव सर्जरीज का एक इतना % देंगे, ओपीडीज का इतना, तो वो भी थोड़ा बढ़ जाना चाहिए। उसके साथ निरामय में कुछ भी एड्स इंक्लूड नहीं है। इन बच्चों को जो A4 साइज शूज लगते हैं, जो भी एड्स लगते हैं, वो एड्स इनमें नहीं है। और गवर्नमेंट के पास से जो भी एड्स इन बच्चों को मिलते हैं, वो क्वालिटी और बच्चे उनको फिट होना, ये हो नहीं सकता। इसलिए ये थोड़ा एड्स का भी इनमें इंक्लूड होना चाहिए। अभी जो इस 7 साल में काम करने से एक बात जो पता चलती है कि थेरेपिस्ट, पीडियाट्रिक थेरेपिस्ट बहुत कम है, और जो भी थेरेपिस्ट है उनके पास बहुत लोड है। तो मैं ये थोड़ा सारे थेरेपिस्ट को बोलना चाहती हूँ कि 1 महीने में अगर आप सैटरडे संडे हमें डोनेट करते हैं, हम कोऑर्डिनेट करते हैं, जो बच्चों को थेरेपी नहीं मिल सकती, जो अफोर्ड नहीं कर सकते, हम उनके लिए ये 2 दिन दे सकते हैं। जहाँ पे बच्चे हैं वहां पे हम उनको ले सकते हैं। बाकी मैंने तो अभी बोला, ये ट्रस्ट और काम करने के लिए ये 3 मेंबर्स है, डॉक्टर तरल, डॉक्टर संतोष जोशी, श्री जागीरदार, उनके गाइड से ये चलता है। थैंक यू फॉर एवरीथिंग। आरुष ट्रस्ट काम कर रहा है, यहाँ पे वेबसाइट है, मेरे फोन नंबर्स है, आप जहां भी आपको बच्चे मिले, जो भी है, आपको जो भी हेल्प चाहिए, मेरा डायरेक्टली कांटेक्ट नंबर आप दे सकते हैं, और हम सिर्फ बच्चों के लिए रेडी है। ओवर टू तरल सर।
Thank you. I have exactly 1.5 minutes and I'm not going to much time. So we are realizing that there are a lot of problems which are common. We are also realizing that there are some problems which are special. Like epilepsy will have some special problems. Cerebral palsy will have some special problems. And we want to enlist that. I just want to end by saying something to all parents, everybody who's here. Just 2 couplets which will encourage everybody. मुश्किल है उस शख्स को गिराना, मुश्किल है उस शख्स को गिराना जिसने चलना ही ठोकरों से सीखा है. So all of us will learn through difficulties, and difficulties make us stronger. Very touched by somebody who said that I am lucky I got epilepsy, and all I have in life, recognition, motivation, is because of epilepsy. I think all of us feel that this neurodisability has given a different meaning to all our lives, whether we are professionals, whether we are parents, whether we are relatives, or the person who's suffering from the disability. And we should take it convert into an opportunity, but that will happen when all of us come together. Thank you very much.
So this is the last session of the disorders. It's ALS, and we have Dr. Dr. Vineet Jason and Ms. Vinder Kaur, if they can come, and after this we'll have discussions and expressions from professionals of the various policies.
Good morning, everyone. It's our privilege to be here today. Thank you for the organizers to invite us and have us here. So I'm a doctor, I'm a neurologist. I practice over in CMC Ludhiana in Punjab. And my center, we look after neuromuscular patients, and ALS is one of the diseases that we look after for these patients who come. Patients come from far, and it's very important. It's a disease that once you label a patient with that you have ALS, it's like that's the end. I mean, I'm sure now that we've discussed so many complex disorders, it's the same for everyone. Like you just said, Dr. How some things are common, and it just looks as though, zameen, paon ke niche zameen khinch di kisi ne. Well, there is also the problem. Many patients don't understand what ALS is. So even if you tell it is ALS, immediately it doesn't strike them, but then they go on to Google and then they search and then it hits them. So there is really no cure. So we are here to tell about what can be done. And with me is Dr. Satvinder and Sukhvinder. They are two sisters who have taken care of their mother, and they will be sharing a bit of the journey and the challenges that they faced during this journey. But what is ALS? We know that ALS essentially is a disease that is a progressive condition. Nothing happens suddenly, it happens slowly. So the diagnosis of ALS is a challenge. So even neurologists or doctors, when they're seeing a patient with ALS, delay the diagnosis because we know that there is no effective treatment. So rather than labeling them with ALS, we would want to delay it till we are 100% sure that this is ALS. Because it should not be that we label somebody wrongly and they turned out to be some other disease. So the emphasis a lot initially is to find a treatable disease, which means the patient undergoes an MRI, has EMG, sometimes multiple EMGs, patient undergoes lumbar punctures, patient has got very expensive PET scans done to rule out other malignancies, expensive antibody testings are done, sometimes once, sometimes after 6 months again, sometimes after 1 year again, and there's a lot of expense involved and a lot of anxiety as to, doctor, what is happening to me? Because there is no one test that you can do and say that this is what it is. So patients struggle and doctors also struggle. Even the challenge doctors face is when you're declaring the diagnosis of motor neuron disease with the patient in a busy clinic, in a busy OPD, how do you be gentle about it? How do you be careful about it? And this is a common problem across neurologists, not just in India. This is there over the world. It is not something unique to our country. And it's very important that these issues be addressed and training be given in life-limiting disorders. How do you break bad news? How do you approach that whole situation? What should the room be like? What should be the time given to such patients? So ALS patients, they have difficulty in cognition, although that's just recently that 50% of them will develop some progressive challenges with cognition, but they develop challenges with speech, they develop challenges with swallowing, they develop difficulty in breathing, which progressively worsens, and they have difficulty with their limbs, difficulty in eating, feeding, they have difficulty with walking, they may develop a foot drop, they may trip over, fall. But most importantly, that we all need to recognize is they're as if they're getting trapped in their own body. Over time, they're not able to move, they're not able to do what is their requirements, take care of themselves, take care of their families, and that becomes a huge burden for themselves, for the caregivers who are looking after them. Again, some things are common, some things are unique. This happens to them from the 40 years age of life, in the peak of their career, when they are so active. We don't know why it happens. It happens to fit people. It does not happen to people who are careless. These are very active individuals who develop it. In fact, a lower BMI is a risk factor for ALS. So that kind of flips the whole thing. Now, what do? Can't we be fit anymore? But there is this huge challenge for us to fight for patients with ALS and give them a hope. I want to hand over to Satvinder to continue the rest of the talk.
Dr. Vaneet and Dr. Nirmal Surya, and organizer, to give us this kind of platform. So as Dr. Vaneet has already discussed about the speech problem, swallowing problem, I think that every body part of ALS patient gets affected, not the brain. The patient is there, it's not on the vegetative state. Don't say that. Stephen Hawking is a living example who lived for so many years and then did wonders. So as we talk about the problems, till the time we don't have cure, we have care. So that's the management, that's the approach. Every doctor, when they diagnose a ALS patient, they should tell that we have a care available. We can do the management of those symptomatic things. And it's not, we can maintain the best quality of life for the ALS patient while they are from the initial stages to the advanced level of ventilator management also. So when we have mobility issues, walker, wheelchair, motorized chairs, and all those lifting hoists also available in our group, people are using that. Then when you have a problem difficulty started with the swallowing, you have a customized utensils. You have you can grind the food. You can use the water thickeners because the water is the basic problem for an ALS patient to drink. So then you can go for peg and rise. So these are the things which doctors should communicate to the ALS patient. Then speech therapies, alarm bell, eye tracker devices are there for the communication problem. And we have a very good 10 years on ventilator patient we were having in our group who was the most active member on the WhatsApp. So communication is the key for a person to survive. Love, care, and support, that's an environmental factor. And I think healthcare and the community need to be sensitized towards the symptoms and the challenges of ALS. So the drugs, the timely decisions of the various stages, that is the key where the management is in taking care. So while we are discussing about the problems and the solution, there's many of them are not aware that this has been discussed here in this room, or maybe the other one. So the accessibility, the awareness between the people is limited. In our journey, we could not locate a single patient, ALS patient. So that's the challenge here. We need to have this information available with the doctors, especially if we are in a neuro conference like this, which can be disseminated to the real patients. Affordability, once they have the knowledge, like people join our group, they have the knowledge. But the devices, the equipments, the BiPAP, the ICU care takes a lot of time. So we need to work together as a team. I think I'll hand over to Swendra on this.
Yes, when we talk about the team, and when Dr. Vineet was mentioning the time taken for the diagnosis of the disease, it's basically the responsibility of a neurologist. But once the disease is diagnosed, it cannot be handled only by the neurologist. If you see the chart and if you see the people who needs to be involved in that team, it's not only neurologists. We need to have ENT specialists to take care of tracheostomy, PEG, and gastroenterologist for the taking care of PEG. Then other stream doctors, be it physical therapists, speech and language therapists, and volunteers. Also the patient support group, which will be so vital in management of this disease. And when we were talking about affordability and accessibility, I'm sure many of you are sitting here. They might not be aware when we were talking about in one of the public forum topic about Disability Act. There is a Disability Act of 2016 in which a central government employee is eligible to be employed as an employee to get a full salary, to get all the increment due if he has acquired a disability during the service. So there is a law, but we are not aware. We are not able to avail it. We just simply resign from the job the moment we get the symptoms. So that is the kind of bridging the gap between the awareness and the accessibility of that thing. Then the next one is very important. That is the care and support that we all talk about. The support groups who are actually living this journey. And just a short video I just want to show you that in case if the care is there is a rehabilitation, we can have this. There's a short video. There are patients from our group.
So this video was shown in the GMR Square at Delhi during the IFNRCON.
People are actually living on ventilators. Ostomy tube.
So I like to finally add just a half minute that what are the action which can make the difference to this kind of devastating disease for the patients. So we need to have ALS in the rare disease policy. So that attention should be given that incurable disease, the life is still important. We need to have some finances available so the quality and the quantity of the life can be extended to a long. Then we need a ALS awareness and building a national registry in India. Then allocation of the fund, like US and Canada are doing wonders there, while India, we are not talking about ALS at all. But yes, good, we are talking in last neurology conference on this. I think, thank you. Thanks.
Thank you, Sukhwinder, and thank you, Satwinder. I know that you are doing a tremendous job. इस सारी चीज को देख के मुझे अभी सिर्फ एक लाइन याद आई है, किसी ने बहुत अच्छा बोला है कि नासा इज लुकिंग फॉर मंगल पे लाइफ. काइंडली लुक मंगल in your life. So that is I think which they are focusing. So we move forward, and again I'm projecting the QR code. I want every one of you to scan this QR code. This will take you to a very simple 6.6 questions, which will sensitize you to the issues which we are discussing today. And with all the support groups, we'll be also sharing a set of questionnaire later on, which will have two parts. One will be the objectives, and the other one will be subjective. You can really express yourself. You can put good suggestions also. So moving forward from this, I hope everyone has scanned this and that has taken you to the questionnaire. So we move on to the next discussion and inputs from our allied public health, rehabilitation colleagues. And we have with us Dr. Urvashi Shah, please, ma'am. Dr. Hitav Someshwar. We have Dr. Kavita Padmanabha. Is she here? Dr. Kavita? Yeah, she's here. Yeah, please. We have Ms. Sonal, and we have Dr. Abhishek. Okay, Dr. Gahan, can you just join? He's on the way. Okay. Okay. So, yeah. No. So, first of all, I want Dr. Urvashi to start with her presentation and her deliberation.
Yeah. So I think the scope of this panel was to talk about each of us in our professions of the scope in neurorehabilitation. Okay, as a neuropsychologist, I think when I say what is neuropsychology itself is a question that I'm often asked as to what we do. So one important thing to understand is that when we're talking about neurorehabilitation, we're talking about the brain. It is almost like every condition has cognition involved in it. So our role is really to work with the cognitive issues as well as the mood and the behavior issues, which are a sequelae of any brain insult that occurs, irrespective of the neurological disorder. So with that, the question that comes to our mind is that what is cognition? It's really an enigmatic term. Many people say, what do you mean by cognition? So cognition is your information processing ability of your brain, your ability to think, your ability to interact with the environment. In fact, it's your very being is due to your cognition. Now, cognition is something that gets affected across, as I said, majority of the neurological conditions. And once cognition is affected, there is a very natural impact then on emotion and mood. And any of the chronic neurological disorders, you will find that emotions and moods are affected. So we have a very central role in neurorehabilitation, which unfortunately is undermined because of the statistics. Neuropsychologists in India, if I give you the ratio, it is 1:26 million. That's the ratio. So we have one neuropsychologist catering to 26 million people. So obviously, this is not going to work despite it being such a great need. Why is it a great need also? Because when cognition is affected, mood behavior is affected, it's impacting education, employment, marriage, all social aspects of life. And the most important thing is Neuropsychological impairments are invisible disabilities. So you have a physical disability, it's obvious to society, it's obvious to everybody, and there is a sympathy and compassion for it. But neuropsychological problems are invisible, they are misunderstood, even by the medical fraternity. It's not recognized, it's not identified. And what about families? I'll just quickly tell you, I remember my first case when I started out 25 years ago of a lady who had dysexecutive syndrome, as we call it. So lack of initiation, lack of motivation, apathy, which are terms which we don't understand very well. Her husband wanted to divorce her because he said she's become lazy. There's nothing else wrong with her. She's lazy. I get patients and families who will tell me, how does he remember everything from the past but cannot remember what he had for breakfast? So some of these cognitive problems that occur are so poorly understood. The person is marginalized. Socially, I mean, in every way, society doesn't understand them. They don't get opportunities. And they're just treated as psychiatric cases or something is really, they're weird, but they're not. So there's a lot of stigma attached to it. And this stigma has to be addressed and awareness has to be created in society about neuropsychological problems that are there. Now, so what do we do in neurorehabilitation? We have enough scientific evidence now to say that you can enhance cognition after a neurological insult. We have strategies, we have tasks, we had a whole workshop on cognitive rehabilitation with 90 people attending. So we have methods, but we need now capacity building of even other psychologists and maybe a transdisciplinary approach where we start training even the other therapists into at least basic cognitive enhancement strategies that we used because of the poor numbers that we have. We have to do psychoeducation. We have to do a lot of counseling with the families and social awareness about these issues so there is acceptance. There are concessions given for education in school, employment. We have to have shelter workshops for the ones who are very bad in terms of their cognitive abilities, I would say. But also we have to also recognize like MS and all, as we said, it's a fluctuating course. There are moments the employers have to be aware and give them concessions for that. And finally, marriage, I think as Dr. Nirmal Surya said, it's not, I mean, they want socialization with the neuropsychological sequelae. They're being marginalized in society. We as psychologists have to provide even those opportunities and more about empowerment rather than pushing them for marriage. So with just few of these thoughts, I think we have a great role and we need to have more awareness about our role.
Hello. Hello. Good morning, everyone. I'm here to talk about neurorehabilitation role as a speech language pathologist and the scope of practice in our Indian population. What can be done and what are the challenges and what are the solutions we all as a team of interdisciplinary management we play. So as a role, as a neuro speech language pathologist, from a medical speech pathologist role or a psychosocial rehabilitation professional, what I know, what I see is many patients with post-neurological disorder in young adolescents, young children, school-age children, adults, earning members of the family, when they get stroke, head injury, or dementia, when they cannot speak, or they lose the ability to understand, communicate, they cannot read, write, cannot go back to work. And are we able to provide them communication, rehabilitation? The second important role of mine is cognitive rehabilitation, which is going hand in hand with communication. So when someone cannot understand, someone cannot speak, read, write, they might have attention, executive functions, memory disorders. With that, they have a psychosocial difficulties to adjust to the changed life, and how that also adds to the communication breakdown, that also adds to the fatigue, that also adds to the stress, and that also leads to difficulty in communicating and recovering on their own when they are not provided rehabilitation from a speech language pathological perspective at acute care when they are diagnosed, when they have been affected, and many of the patients in India do not have adequate care at hospital because of lack of manpower. We do not have the speech pathologist in neurology and neurosurgery wards who can help them and train them. Second, and I would say first, the vegetative and important function is the swallowing, the nutrition. So speech pathologists are important for swallowing and deglutition disorders rehabilitation also. So many patients do not have adequate swallowing function. They choke, they cannot eat, they cannot swallow, they cannot swallow their own saliva. So having the first important safe swallowing for life-saving skills also is important. We do not have adequate manpower in Indian hospitals to even cater the swallowing disorders, not just neurological, but there are onco disorders also. So neuropalliative, oncopalliative, rehabilitative, neurodevelopmental palliative, when we have many children with cerebral palsy who have difficulty in swallowing. So they also require adequate early identification, adequate assessment, objective and subjective rehabilitation, the patient perspective, and the parent or the spouse or the children perspective, and then how we can make this person's life better and his quality of life. As I want to quote the Sukhwinder said, there are no cures for many disorders and there's care available. So we need to advocate right treatment, right services. Where are they available? If they are not able to take it in person, we need to make the person get the adequate rehabilitation available on hybrid mode where they can have few sessions face to face and few on a teleconsultation mode. So neurologist, neurosurgeon, general physician, psychiatrist, surgeons, general medicine and cardiologist, these important medical professionals, we need to get the referrals on time, and the acute care intensivist to have a speech therapy, physiotherapy, audiological rehabilitation, the occupational therapy, psychosocial support from psychologist, neuropsychologist, social worker, nutritional. This is very important teamwork. We need to work together. And next important thing is disability certification. If they really are they coming to satisfying the criteria of disabled, they need to be given adequate information about what are they entitled to, what the families can avail, the rules, regulation, the criteria, where to get assessment, where to get the certification, what would be they getting the employment, and helping them to back to the society is important. No matter if they are not able to communicate, not able to read, not able to walk, one has to really help them return back to community as a self-dependent person and not crippled somewhere completely dependent on someone, so that they will have a right to live meaningfully. Thank you so much.
Next slide. I'm Dr. Kavita Mahamantar. I am an occupational therapist. I have my PhD also in occupational therapy in neurorehabilitation. The types of impairments that we generally see in OT can be a myriad of them. The main thing about OT that I want to mention is that the diagnosis is not that important for the occupational therapy process. Since occupational therapists work with patients with any kind of issues in their activities of daily living or whatever they do to occupy time, which could be work, school, leisure activities, hobbies, anything that they find trouble with, the diagnosis doesn't really, guide our thinking, other than the fact that it helps us know the progression of the disease and the recovery that is expected. But we can help children, who are newborns, from feeding problems to our aged and older adults, like my colleague mentioned here, for palliative care. So occupational therapy has a role in all of these areas. Everybody has talked about the team and the importance of the team, so I won't reiterate it. But it is extremely important to be in touch with each other so that these goals can be worked together. There is good overlap and not necessarily misinformation being presented by different team members. The process includes evaluation, goal setting,
discharge planning, and education and counseling each step of the way. We all, have heard disability evaluation certificates being provided. We know here in Mumbai, it's provided by BMC hospitals. And then work-related adjustments can be made based on that. This is tele-rehab, which is done for a patient with MS in Jhansi. She visited her daughter who was in Bombay, had come for an evaluation and is continuing care with me via tele-rehab. It also helps for people who are unable to travel, have financial concerns, because tele-rehab is a slightly cheaper option. If they have lack of social support, to bring them to centers, or there are lack of occupational therapy services, as one of the person mentioned. There are not as many therapists, just like there are not as many neuropsychologists. The psychological impact, we have lots of support groups. We've heard from people. That is something that can be promoted to our patients. We can actually count on friends and families. I think nowadays people start feeling कि मैं उनको कैसे तंग करूँ या मैं उनसे कैसे पूछूं. But we really need to have a network of people, friends and family that we can count on for things. And of course, there are many NGOs that provide subsidized care as well. And then, of course, all of this is very important. It's more important for you to hear from Vasudha instead of me, because she is one of my patients whom we have rehabilitated back to work, and she'll explain all of that for you.
Thank you very much. I'm really blessed to have been surrounded and supported by all the good people all the way, because the disability that I am undergoing right now is accidental. I was not born disabled. It is a result of an accident which has given me this disability, and I know that I'm going to be this way all throughout the life. So I don't call myself disabled. I say I'm differently abled. So Kavita really gave me confidence. I was working in school when I met with the accident, and she helped me rejoin the school. She came with me to the school to see where do I sit, where is my sitting arrangement, how's the chair that I've been given. Because see, we teachers were given revolving chairs. So in order to be confident to sit on the chair, like ma'am was holding the chair when I came, I said no, because I have been taught how to. So she told me how to sit, how to ensure that I will sit on the chair and I will not slide down. Okay, so that is a different confidence. Plus I had to use my hand, because teachers, they have to write on the board, they have to erase whatever they have written. So how do I do that? Sometimes I faced problems while turning. I would lose my balance. So she taught me how to do that. And initially, even my speech was not clear. She worked with that also. Like to speak slowly and stressfully that way. Now whatever I speak is properly understood by people. Earlier, the speech was also not understood that way. So it has really helped me a lot. I'm really thankful to Kavita.
She is a teacher in Dhirubhai Ambani School, and she finished her master's after she had her traumatic brain injury. So kudos to her for that.
Hi, I'm sorry I had to join late. So I'm Heta Someshwar. I'm a physiotherapist, done my master's in neurophysiotherapy. We all know what physiotherapist is. We require a physiotherapist someday or the other in our life. And I have seen patients, like we generally see patients who are just born till they are 99, 100 years old, till they live. So everyone requires a physiotherapist some way or the other. What a neurophysiotherapist does is we take care of children with special needs. We take care of children who have birth defects or who have certain other abnormalities or have had injuries because of certain reasons to the brain, like insults, because of any trauma or because of any infections, or because of malnutrition also that generally occurs. And then we take care of adolescents, we take care of young adults from the age group of 18 to 45 also, when they go to the offices and they have back pain, neck pain. And we even take care of children who have transitioned from being into the pediatric population coming to the adults. So we always have this transition phase and a transition OPD between the age group of 16 to 18, where that's an area where a pediatrician doesn't want to see them and a neurologist doesn't want to see them. The same happens with us also in the place of physiotherapy. Like there are certain people who are pediatric physiotherapists and there are certain patients who are adult neurophysiotherapists. So that gray area of that 16 to 18 years, because they are also growing. So the hormonal changes that are there in the children is something that we need to address. And there are certain doses of medication that an adult physician or an adult physiotherapist would know better as compared to the pediatric physiotherapist. So that's one gray area in which we are trying to work. And definitely through this forum, we are going to promise to you that none of our children who are becoming adults are going to be lost or are going to have some sort of problem in terms of getting physical care when they are transitioning from the pediatric age group to the adult age group. Then we see patients, we deal with geriatrics as well. People who are above 60, they're young at heart, but the body is getting old. So even without any disability or without any injuries, we do deal with geriatrics also. We call that as healthy aging. We let them grow better, like, have a better aging process, because aging, we cannot not age. So the day you're born, you're going to age. So you can't be the same that you were yesterday when you're today. So a graceful aging is what we term that. So we do take care of these patients, not patients, these individuals as well. And yes, the Prime Minister this now says, be fit India. And we do deal with a lot of fitness, a lot of counseling, a lot of sports rehab. We have our neuro patients with spinal cord injury. We have patients post-traumatic brain injuries. I was lucky to help two of our Paralympics basketball team members get rehabilitated at our center at Nair Hospital. And we had one young stroke who represents the Maharashtra police team in athletics. So yes, we do deal with that. We make your hobbies useful for you. And we work more with the cardiopulmonary endurance as well. And you're more than welcome to come visit us and ask us any questions that are there. Don't be afraid to come to us, and we are there for you. And at the end of my time that I have given, we all say that it's a multidisciplinary team. And we always say team means together, everyone achieves more. So we all work together, and that's how our patients and we ourselves would get more benefits. The mortality, the morbidity would reduce, and the quality of life will improve. So please do visit us, and thank you.
Hi, I'm Dr. Abhishek Srivastav. As we all know, persons with neurological problems have multiple impairments, multiple issues. Even top to bottom, people have cognitive problems, thinking, memory is delayed, attention is difficult, they have vision problems, neglect, they have behavioral problems, sleep issues, pain, they have speech problems, language problems, swallow issues, motor deficits, sensory deficits, bladder bowel problems, sexual issues, the list goes on. So our job as a physician who works in rehab is to identify all these problems in detail as the first thing, and then treat them with the help of a multidisciplinary team. Second important concept, this is called as impairment-based approach. You treat the impairment, you reduce the long-term disability to happen. Second, patient in the acute stage needs rehab. And at that time, they have medical issues, they have diabetes, they have hypertension, the GCS is poor, they have tracheostomy, they have RT, they have Foley's. So important point at that time is to provide continuity of medical care. And second, identify, prevent, and treat secondary complications like aspiration pneumonia, urine infections, pressure ulcer, contractures. If there are these problems, they're not fit for rehab. So you have to prevent these complications, and if they happen, treat them so they can participate in the rehab process. Third concept is to provide continuity of care services. We all know we have good ICUs now, we can save lives. Patient come to ICU, even big massive stroke, you decompress, if worsen, they do a CPR, still you survive the life. If they survive, it's problem for everybody. They come to stroke units, they come to high dependency units, we manage them, there's no place to go. Can they go home? The per day of cost of therapy at home, managing them at home is 1 lakh rupees a month. So you have to ensure systems of care, you have to ensure proper transition of care from acute hospital setting to either a home-based system or outpatient-based system or long-term community care systems. Next point is these persons with disability, those who have moderate to severe strokes or brain injuries or Parkinson's or MS will have some residual disability. The disability has to be assessed, has to be certified, and government is providing a lot of resources now. So you have to make them aware what resources government is providing, ensure they get certification and assessment, and they get proper utilization resources available from the government. It's a very important part of the overall rehab process. Another important point is these patients also require, as continuity of care, where the funding comes from. Can they get medical insurance, access to medical insurance? If not, how can you make it happen? We have patients who have need repeated hospitalization after stroke. Number 3rd admission, number 4th admission, insurance says not allowed. So you have to provide some justification. You need a good medical background to understand and support those in that time so they get adequate utilization of the insurance process what they have. Another issue is we all are team members sitting here. Somebody has to put them together. You don't put them together, it's of no use in long term. MDT team has to be working together with the patient centered. Some glue is required. So I am the glue, you can say I am the glue to keep all people together. Research have shown that, especially in the acute, subacute stage, physician supervised rehab programs have better outcome, reduced length of stay, better prevention of mortality, less morbidity, but long-term outcome. So I would suggest one simple message to all of you, wherever you can go back, if you can start at least as a first step, inpatient rehab units. So patients who need rehab when they have bad medical problems should not be sent home directly in the hospital. What normally happens, you have a stroke or a brain injury, ICU, out of ventilator, tracheostomy, send them home because there's no place to manage them. So I sincerely urge to all of you, especially physicians, if you can start a simple acute or subacute inpatient rehab units in your hospitals, patient can be managed and a proper transition of care, we can make it much more cost effective in long term. Thank you.
Thank you all for the wonderful insights for the scope of neurorehabilitation and especially for the Indian public health perspective. We'll move on to the next part of the program where again, I'll request everyone, if someone has not screened this QR code and has not shared it further. So we'll continue with the panel discussion, and I think please, we can have the chairs, please. And I would like to invite the panelists to the dais. We have already Dr. Abhishek here. Dr. Anurag Sharma, please. Dr. Arpurva Puranik, sir. So can we have all the chairs down? Yeah, so that would be better. Ma'am, please take care. Yeah. With this, we can have it. So Dr. Atul Thakur, please. Yeah. And we have Dr. Kavin. Yeah. Dr. Biplab. Dr. Deepak, sir. Dr. Hitav is already here. Dr. Janti Mani, ma'am. I think she's in another session. Dr. Kavita. Yeah. And Dr. Guhan. Is he around? Okay. Yeah. Okay. So, yeah. We can make a semicircle type of thing. I think that will accommodate more people. So, Dr. Purnima Gauri. Dr. Purnima Gauri. Satwinder. Ms. Sonal. Dr. Taral Nagda, sir. Dr. Vineet. And Dr. Urushi. Yeah. So do we have around 18 chairs? You can use these two also. Two. You can pull this table over here. So I think we'll have the panel discussion from this place only. So first of all, thanks for everyone to stay back and then join this panel discussion. We'll be projecting the question also so that because we are recording and we are live for this program, and we want everyone to understand the set of questions which we are going to put have been they are based upon the inputs from you as well as the other stakeholders, and we have tried to cover as far as possible the scope, the challenges, and obviously this meeting is actually focusing on the solutions. Now, what's the way forward? How we can really bridge that gap? So we would like to have the comments. Please keep your comments brief. Again, as a timekeeper, it's rude, but I am allowing only 45 seconds for your comments. You have to make up your mind for the question. So the first question is for Dr. Biplab. Okay, so in your opinion, how frequently are both indoor as well as outdoor patients with neurological disorders that require rehabilitation programs, and what proportion of these are actually referred?
Yeah, hello everyone. So before taking these questions, just let me give you a fact. The fact is that I'm a clinical neurologist and doing neurointervention as well. So in our hospitals or any center, there are a significant number of neurological disorders, which is progressive degenerative disorders. Number two, there are acute emergency conditions, say for example, stroke, where the role of neurointervention is immense. I mean, like it's immense and very highly required. Why it is required? Because I will give you an example. The same thing I said earlier as well. For stroke patients, not only in India, all over the world, they come within the golden hours. We talk about golden hours. We always talk about in all conferences, golden hour, because we say that there are very effective treatment. You come within that hours, you will remove the clot. We do that, and you will be absolutely fine. So coming within the golden hour or window period in medical terms, whatever we say, the patients can be better. But in that patient also, more than 50% or 60-70% will require immense intensive neuro rehab. Leave aside the 90%, because within the golden hour, the person reaching within the hospital within the golden hour will be very less, like 5-6% of patients. So more than 90% patients are not reaching in a center within that golden hour. Saying so, it means that more than 90% will come with some sort of disability. Then where they will go? They need neuro rehab. They need a team effort where the persons, as Dr. Nirmal Surya was referring, wonderful effort, make the person independent so that he or she can be, they independent, they live with dignity and then they live in a proper way. So that's where we need to have a system in place in every hospital if possible. The neuro rehabilitation programs. Coming to the point of your questions, in my IPDs, more than 60-70% patients require intensive neuro rehab programs. Coming to the OPD patients, yeah, around 20-30% patients which really require neuro rehabilitation programs. But whether they are being referred to in centers, that's the complex thing, because patients, well, they go back, though they don't find a center which is nearby neuro rehab center. That's a facility is not available. And that's where we need to work. And whether there is so many other roles of social media and other things or web-based things. Thank you.
Thank you, Dr. Biplab. Is that moving? Okay. 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 So the next question is for Dr. Sonal. What are the common constraints and limitations for providing acute neurorehabilitation care? Just focus on this particular topic.
Thanks for this relevant question, which we see that majority of time patients with neurological disorder require physical therapy, speech language therapy, and yes, respiratory therapy. So in acute care, what are the needs of the persons with aphasia, dysarthria, dysphagia, hemiplegia, vision difficulties in seeing? So it depends on the symptomatologically, but then what we have constrained is we do not have a trained manpower. We do not have a full-time rehabilitation professionals in acute care of neurological rehabilitation. Many a times we do not have people providing the adequate care. The referrals are not coming because the nurses do not know whom to call, reach to, be it medical institutes or tertiary centers. We have even difficulties in communication among each other. So there are many constraints because the quality of care is not provided, because of the number of patients are really high, and the professionals in the hospitals, clinics, polyclinics or tertiary centers having the acute care setup may not be really meeting that. So these are the constraints. Next is the patients, if they do not have insurance, they are not insured, then the cost of rehabilitation in acute care, they would feel that life saving is first important for my patient. Do not start this rehabilitation if that is charged. And many patients, if they are below poverty, then also it is important that we need to see the affordability of the neurological rehabilitation professionals, the charges, hospital care, and these are something which we really need to work on. We do not have government system to really help and work on the rehabilitation.
Yeah, the brilliant insights on the topic. Thank you for the deliberation. The next question is for Dr. Vineet Jason. So in your experience, how effective you have found that the patient neurorehabilitative pathway? So Sonal has talked about the acute care. Dr. Bipla highlighted that there is really a gap between the need and the people who are really referred for the neurorehabilitated. But post-discharge, how effective you have found that the neurorehabilitative pathway has helped actually, or is there any advantages of creating such pathways?
So I understand it's post-discharge.
Yeah.
So post-discharge rehab is always difficult. It depends on the disability the patient has. And if they're significantly disabled, then tele-rehab has been a huge boom, which has recently just taken on a lot of role. But apart from that, those who can access the facilities for rehab, they get very good care. But we know those who need rehab very often find it hard to access. So multidisciplinary care becomes a challenge because time consuming. Every therapist needs their own separate time. That is probably something we need to work on, how to make that more effective.
Thank you. So I would like to, this thing is not working. Something more effective to change. Please change the next slide. Yeah. So this question is for Dr. Kavita and Dr. Hitav. What are the challenges you face in the current referral system? Like you face that there are certain barriers for or comment upon that patients are not referred to you optimally or on time for neurorehabilitation.
that does happen. So one of the things is that we do not get a referral on time. We get referrals, especially for occupational and physical therapy, maybe 5 days, 7 days, and in some cases, even more time post that. And we lose out on the initial, part of neuro rehab, which is so crucial. We all know it. And one of the things that I would say would be a solution is to have a case management type perspective that we have abroad, where there is a case manager who addresses inpatient concerns and follows the patient through outpatient procedures and various other, and also that person can then be in charge of making sure that the entire team is accountable to that person. So that's mine.
Yeah, very nice. So, yeah, Hitab.
So we've seen a recent trend, change in the trend. We are getting referrals, but the main problem here is the counseling of the patient. The patients are not counseled to the importance of rehabilitation. And they'll be like, हाँ उधर जाओ झाड़ के नीचे कसरत करवा देंगे. So the residents, they need to be hammered. The SMOs, they need to be known that referrals are happening, but counseling and the importance of physiotherapy or importance of rehabilitation per se has to happen at the ground root level, sir. So that is what we are seeing.
So sensitization of the medical team.
Medical, not the
And I
neurologist
think-
or a rehab
So
physician.
that brings us to something that there has to be a neuro-rehabilitative pathway where the team is informed about the case properly. And I think there has to be, has to be a bilateral communication.
Because
That what has
otherwise
been
we
the
lose
progress.
patients to
So next slide, please.
compliance.
Yeah, thanks, Hita, for the brilliant insights. Next slide, please. So this is for Dr. Anurag. So yeah. So can you comment upon the accessibility and the effectiveness and the affordability of the current neurorehabilitation programs which are going on for the various chronic neurological disorders in India? So three things: accessibility, effectiveness, and affordability.
See, so we have to understand that most of the India actually resides in villages, right? And as a population, if you see that people are not reaching there, but now with the technology as it is reaching it, and our perspective is changing. So accessibility is difficult, but then people are taking step today. Now there's a possibility, as it was shown also, that that you can do teleconnect and you can tell them, you can keep on taking. Someone needs to motivate them, and that can be done. So that is how the distances are becoming smaller and smaller. They can maybe make one visit in a limited time, 3 months or 6 months, but they have to be continued to be followed up. So that covers the accessibility. Effectiveness, yes. So now, since people know and people have started understanding its importance, so as compared to, I would say that what used to happen about, say, 10 years back, now outcomes are different. Now outcomes are getting better, and there is a the people are putting their more energy, more soul into getting good outcomes. And not only it's happening by way of these conferences, when they meet, they showcase also which motivates others to do better. So yes, that part is also there. So effectiveness is increasing. Affordability needs to be, it needs to be considered. Now, affordability, there are two parts of affordability, in the sense that, see, the big thing, getting the machinery, getting the systems, which are requirement in the acute case, acute stage, someone has to pay the bill, right? It cannot happen that it can be given free. In hospitals, it is there. In the majority of the big hospitals, it is there. But that is something probably we should be focusing more on it. But the good thing again about it, this is most of these events which are happening, they are covered from day one on insurance, except for the certain diseases. So for example, like accidents and all. So the insurance would cover up. We should bring in that the importance of having the insurance to everyone's mind. I think, if I am correct, the penetrance of insurance is about 14 to 16% in India. So that needs to be increased. More coverage. People should understand that, nowadays it is the 3 lakh rupees is not sufficient. So they have to get the cover for more. So that is how they can actually cover this gap between the affordability. But yeah, this is, I think, in these three things, this is the most important thing which we should look into.
Thank you, Dr. Anurag. I think we need to address the issue of cost effectiveness also. We discussed the direct and indirect costs. So when it comes to affordability, I think that's a good investment to reduce the duration of the disability or the degree of disability. so that it ultimately translates into better cost effectiveness. Can I have the next slide, please? Excuse me. Can we have the next slide? Yeah, this question is for Dr. Dr. Punema. To what extent do you think societal stigmas are associated with neurological disorders in India and that affects the rehabilitation programs?
Societal stigmas do matter a lot. In fact, psychosocial issues as such together, you can't separate psychological from social issues. And we see them mainly in epilepsy, but we also see them in other diagnoses such as Parkinson's disease or even dementia. Rehab is important in dementia as well. I had one patient who hid the diagnosis of a Parkinson's even from her physiotherapist. She felt so stigmatized after that being diagnosed as Parkinson's disease. So with epilepsy also, when we started working with epilepsy people in 2008, at that time, I realized that we had programs for epilepsy people, and we were telling them that 80% of people with epilepsy are going to live normal lives. So they wanted to be seen with other people who don't have epilepsy. They didn't want focused programs at that time to be seen only with other epilepsy people. So I have found that integrated programs with everyone together have a better result. And yes, stigma is there definitely for many neurological disorders because neurology is a system of our identity. So any neurological disorder affects the identity of the individual, and that creates the stigma to start with. So accepting the diagnosis is the main thing, and awareness of the society is a very huge challenge, which is why we feel that for epilepsy, if we can have in the 6th, 7th, 8th or 9th grades textbook, either in the language textbook or in the science textbook, a chapter on epilepsy, its types and how it has treatment. If we can have something like that in the textbook of school children, in whichever board it is, that will really be great because teachers will be teaching that topic, so they will get sensitized and students will be studying for that. So I think that is one way of doing this.
Thank you, Dr. Punema. Next question, please. Yeah, so this is for Dr. Abhishek. So now we have come to that there is a team that is required. So can we have a comment upon what exactly constitutes an ideal neurorehabilitation team, both for acute and for chronic
So as
settings?
there are multiple impairments in neurology, you need a team, and that team has to be physician supervised, either a rehab physician or a neurologist trained in neurorehab. Then we have all team members, neuropsychologists, speech language pathologist, a physical therapist, an occupational therapist, a rehab nurse, a social worker, an orthotist, nutritionist, and biomedical engineer. All has to work as a team. The team has to be patient-centered, and the team works in a different way. There's no medical model of care here. Either it's a multidisciplinary model of care where one person takes charge of the team, he works for everybody, meets every week, discuss goal, planning, progress, take it forward. India right now, as we don't have very advanced healthcare system economics, MDT is a good approach to begin with. The systems mature. It's something called as interdisciplinary method of care, which can happen in due course of time. So a team should have all constituents if possible. If not possible at a peripheral area, even if you have basic 3 or 4 members who can actually sit together every week, discuss patients, even on phone, telephone, online. If they can have basic meetings to monitor the progress, do goal planning, also works equally well in long term.
Thank you. So the next question is for Dr. Urvashi. What is the status of the facilities available in the government and the municipal hospitals currently, and how you think and you can suggest them to improvise?
So I think I work in a government hospital, and at least the major government hospitals will have a department of physiotherapy, will have a department of speech therapy. Psychology is still not there in the government hospitals. So as a psychologist, I would say this is a great need that we establish these departments. They are completely under-recognized. But I think what is more important than having those departments in the government hospitals is the lack of interdisciplinary dialogue. So I've seen, personally at the KEM hospital, there'll be the departments, but each is working on the patient individually. Like the physiotherapist will come and do something and go away. The OT will come and do. The psychologist is rarely called in. So nobody is sitting together and talking. So this approach I think if we tweak that and introduce some of the more elite things like psychology and others, in government hospitals, we can offer at that low cost model that you're talking about a lot of things, but we need that coming together of the various departments and forming a team.
Thank you. I think that integrated approach is something which has to be stressed upon. And again, the communication among the various specialists. So the next question is again for Hitav and Dr. Kavita. What are the challenges in administering, if you talk about making an individualized rehabilitation program? So what are the challenges? Maybe it could be from the family, monetary or anything.
So from an occupational therapy perspective, firstly, a lot of occupational therapists work similar to physiotherapists. So the patient's first question is, why am I paying you for the same services? So firstly, I think within my field itself, we need to ensure that occupational therapists promote activities of daily living, which are our bread and butter, as well as a return to work, as mentioned by my client. Other than that, of course, getting to the facility, if they don't have social support, if they're not mobile themselves, financial constraints, because now they've already paid for all their medical services and now we're asking them to pay for therapy services. Also, especially with neurological diagnosis, it's not a short-lived, other than if it's for BPPV or when it's short-lived and therapy is going to last so long, for stroke, for Parkinson's, for ALS, for epilepsy, for any of these conditions, therapy is a long process. So understanding that we have to be in therapy for a long period of time also sometimes is difficult for clients. They feel like they've gone to the doctor, gotten the medications and felt all right. Then why is it that in OT and PT they're not feeling all right in 3 or 4 sessions?
So Hitav, I just have a corollary for you. Do you get any feedback specifically from the any formal way of getting the service quality I'm talking about?
Yes, sir. So I work in a government sector, and what the feedbacks is a little difficult for us to get, but we do it on a certain level for our own satisfaction. And a few of our students are doing studies on this, to understand the level of empathy among the physiotherapists and the level of patient satisfaction and correlating empathy and satisfaction to the therapy. And it gets difficult to, sir, because we have an enormous OPD load. So to get everyone's feedback and spending time is the problem. So main is the number of patients and the number of therapists ratio. That is the main, most important administrative point that the government through our medium should be sensitized about, that we need more people to work.
Yeah. So I think what has come upon is a pathway, communication, integrity till now, and bilateral talks. So we have talked about that there is to be communication with the family. So I'll like to have inputs from Satwinder. So how do we feel that sensitizing and training of the caregivers? I think there is a lot of experience with you as well, and the family members that can play a role in neuro rehabilitation.
I think that sensitization of the caregiver for the diseases in neuro case, basically, because there is hardly not much cure available. So we fall in that critical component here is the caregivers. So if caregiver is given right information that this needs to be managed this way, and you are expecting in this kind of disease, these are the different stages. So first of all, the first more prime important thing is just give them hope. Just give them some positivity, because once you have that frame of mind with the caregiver and the family members, the half battle is won. And then again, if you don't give any hope, the half battle is lost. Even the cure or any treatment is available. You provide all the information, and you can't give us blank hope ki bas sab theek ho jayega, you can manage everything. You need to provide a toolkit. When we say toolkit, for every doctor should have for particular disease कि ये चीजें आपको आने वाली हैं, ये चीजें आपको करनी हैं. And I think that when that awareness comes within the caregiver and the families, the life would be very much easier for the whole journey of that neuro disease.
Thank you.
I think that's what.
Yeah. So this question is for Dr. Taral actually. So I think
if this is what is done, what you are going to achieve, this is what you can achieve, this is what you cannot achieve. That should be very clearly explained. And I think this is what this discussion should be. What we are doing, they all know. But what patient's point of view, we need to highlight them. What are their problems, what they feel. I once again told you that we are looking at our delivery because we are trained to just deliver services. We are not trained to sensitizely listening to the patient. And when we have a pain in the back, how do we react? Taral will tell you now how he reacted. What are the things came in his mind? When I will walk. If you are not walking for 3 months, every day you will think, when I will walk. When you start walking, you say, when I will leave this stick. And then when you leave the stick, then you say, when I will be able to run. So these are the things which really matters. And that is where our support groups and our doctor has to get sensitized. And I completely agree with you and I endorse you. And that's why I said, what are the patient's perspective that should be discussed more.
So I just,
And we like such toolkit to be existing for every disease in India. So that toolkit, that program, once given to the doctor, they are able to give first hand ek tarah ka pura ek document that whatever you are going to have, these are the solutions, these are the management options. They can explore and innovate from that area, so on. So I think that's really required. Nahi to people are just confused ki kya karna hai and all that.
Can I just say that why can't we work towards a common toolkit for neurodisability? Which where there are commonalities, so many commonalities. Maybe IFNR can look at.
So I think we can have the inputs from
It
the
is doable, yeah,
family
it's a
also,
doable thing.
that how they feel that they settle.
so I think I agree with Dr. Surya that all the doctors here who are present are professionals. Our dual role to play. We provide professional services, diagnosis, treatment, etc. At the same time, patients look up to us for guidance and mentorship. Unfortunately, what happens in a medical college curriculum, I was taught how to diagnose and treat a patient. I was not taught how to put a hand on the patient's shoulder and tell them कि सब कुछ ठीक हो जाएगा. Don't worry, we are with you. And that training is absolutely essential. And what in yesterday's AGM, what really excited me were not the high-tech robotic workshop, but the workshop which Abhishek and Hitav and Sir proposed on the family rehabilitation. And this is something which is low-tech, which is low cost, and it can be easily scaled up. I think this is what all of us should be trained into. The doctor should be trained into being a social worker and a caregiver rather than a cure giver. That's what I feel.
I think this is a very valid point about medical education. All of us were presenting the cases in front of the faculty alone, and we were competing among our peers. We were never told how to build up a team and how we can help reach. We were not focused on the patient at that time also. We are sometimes not focused on the patient right now also. So our brains have been tuned how best as an individual we can perform, but not come up with a team. So that is something which they were saying that is essential. Yeah, medical model of care, not the, yeah.
Quickly, what I would like to add is even among medical and allied healthcare professionals, we do not have communication. So that is how we don't have a gap to be filled. Who is referred, where you have to go, where you have to recommend, who will see you, did he see? We do not have this among us. Maybe an app can help, which should be there mandatory, and then maybe something like that we should be able to fill the gap.
Yeah, hi, my name is Sachin Gandhi. I'm chairman for Arush Trust. Rushali has been speaking and Dr. Taral and Shreyas have been speaking about these things. And in fact, yes, actually what first thing that Nirmal sir talked about is we need to have a kind of a unified approach towards neurological disorder. That's the number one thing. Because every avenues that we are talking about, and I come from a mechanical as well as a IT background. So there, one of the things that is taught to us is break it down and then reformulate it to one point where everyone can refer to the same factors. what we talked about today, I think as a parent, as an NGO, I think we talked about lack of awareness. We talked about communication. We talked about economical pre and post issues that patients face. We talked about stigma. Every neurological or disorder has stigma. Rushali, on the day when she gave birth to Arnav, my son, was stigmatized by the doctor. He said, "Ki, you didn't use enough efforts because of which your child is born like this." So if you look at it in that manner, things are very difficult. Caregivers dilemma is there. Again, we are talking even about one more thing which occupational therapists use is gamification of whatever we are doing, because simpler you make it, it is easier for the patients. And parent champions is what I would say is the best way to handle things like this. We are parents, we are champions of our own kind of disabilities. We feel we want to do it bit better because automatically my child will also go, along with that all my other children will also go in the front. One more point I feel very importantly is therapies are important, and which every avenue has to be coming into perspective. That is also important. There, I would say one part which I felt missing, I feel that you are all seniors, you are all specialists in this field, is what is going to be the next step. So there are microbots which are coming into perspective in medical science. There is what you call impairment which has caused you to some accident or something which can be taken care of going ahead, can be rectified. Like you are limping, doctor puts up a particular thing to that particular bone, today you start walking. So is that impaired, which is an induced impairment or a kind of a historical impairment? Can you deal with that? So these are another things which we feel about. And as an important part, in fact, when we started our NGO 7 years back, we were parents 3 years before that, and nobody used to hear us or listen to us. Today I have got Dr. Taral, Sriharsh, so many people whom as one of the patients said, ki, we got the best people around us. We also got them. And they told us, ki, don't become only parents. Have your own identity and become your own champions. And we started the NGO. Today, our NGO lookout is not to create a building, to put a child which is with CP inside a building and take care of it, whereas the parents are living somewhere, their siblings are living somewhere, all these stigmas are there. Our intention is to become that communication gap. Who can better understand the communication is the parent champion, who can understand what they want and what you can give. And one of the bigger problems is therapists, doctors, they are not going to get time. We are a billion people country. We are not going to get so many specialists. So the best way is optimize by using somebody in between who is a parent champion, bring him into it. We are doing right now for 23 institutions who do not understand what should be done for our children. Their own people, they're all CP NGOs which are there. And there are 3 hospitals who take us for a counseling, parent counseling OPD. So we try to give them an understanding what is going to be there for you in the future. So that's where I feel we can work towards. And I think all your guidance, your subject expertise is going to help the patient like what sir talked about. Thank you.
Thank you, Mr. Mohammed. So I think that's a wonderful way of approaching all the adversities and turning them into opportunities. So I think I would like to ask from Madam, like what have you a role of ambassadors, how they can really basically convert this awareness. You can create awareness using ambassadors, and you can advocate about a disorder, and their social impact can be reduced.
Hello. Yeah. So all of the disorders which are discussed now, I would also like to add very important 5 some more groups into it. One is the suicidal attempt people make. So any kind of suicidal attempt is going to hammer the brain. It's going to disable the brain. So that has to be included. Secondly, post-COVID has to be included. That is a new thing. Third thing is visually impaired, because retina is the part of the brain. And I have been working with National Association for Blind for many years. And I have been working with them for memory and cognitive impairment. So that group has to be considered. And third thing is about substance abuse. That has to be considered because that is going to affect the brain. And most importantly, like ALS, there are other rare brain disorders like rabies encephalitis, autoimmune encephalitis. So such people are all behind the curtain. They are not coming forward. They are going here and there, not getting the answer. Now, as far as dementia is concerned, we have been gathering memory clubs. And also, as I have been working with different civil hospitals and we are connected with memory clubs and so on. Also, ARDS and Nasik chapter we are running. So under that, bringing all these together and through civil hospitals, because as more than 15 years, I have been working in dementia and all these things. When I started with doctors, making them understand why they need memory and cognitive impairment.
Yeah.
So
What role ambassadors you feel that can play in bridging the gap of the awareness and advocacy in India?
yeah. So looking at the number of population, we need certainly government attachment here. So through how we can do it, that is the one thing. And the campaigns need to be run by, that's why I said civil hospitals would be a really great thing, because when I'm working with rural part, we can see the gap in there. So I think we are not sufficient. We need government. And secondly, as ma'am said, we don't have a psychology council of India. You can imagine mental health is such a main part of this line, clinical line, but we don't have it. So these are very important things that we need to consider.
Thank you.
Thank you.
Thank you, ma'am. Because Dr. Purnima has been working for the cause of epilepsy, and I think there is a role for, we have beautiful ambassadors over there, live examples. And
Epilepsy Foundation has so many ambassadors.
a big round of applause for these ambassadors,
Yeah,
actually.
definitely. So when someone who is going through that problem becomes the ambassador, it is the best possible solution we can have, because when others look at them and they realize that, oh my God, she has this, and look at her where she is now, I could be in her place. So the person who is newly diagnosed with something, let us say epilepsy, they look at one of our active ambassadors and they see that, okay, this is what she has achieved, I could be in her place. It's a very, very real feeling. It's a very real feeling. And also, if we can rope in some celebrities to talk about that cause, that also becomes a good statement for a support for our advocacy mission. So people who are going through it, giving them a stage, giving them a platform where they can express their success stories. Now, a simple thing like carpal tunnel syndrome, you Google and you'll get blogs of patients. Usually patients who are not doing well will write those blogs. Ki mere sath ye hua, itna bura hua, and all those things. Usually people who are coping well don't write blogs because they're doing well in their life. So giving this social platform to people who are actually good copers with whatever they're having, it is the best method of advocating for that particular mission for
Thank
any
you.
disorder.
Yeah, so Dr. Purva sir, I would like to have your insight that where does India stand currently in relation to neurorehabilitation policies, and what role, as highlighted by Madam, the India government should play in providing the neurorehabilitation services?
I may not be fully aware of the government situation, but as far as I know, the rehabilitation policies are there by Government of India, but pertaining to neuro rehab, I am not aware whether there are any government policies. I think whatever white paper we will make, that will shape the policy in coming months, and the hallmark or the salient points of that neuro rehabilitation policies will be the same as for any other general rehabilitation policy, with some specific additional features for neuro rehabilitation. It will cover, it should be broad in its sweep, right from the early stage to late stage to middle stage, right from individual profession to teamwork, right from involvement of patient and caregivers and all stakeholders, right from education and awareness and training. So that policy should be very broad, and it should be widely available. That means going up to the peripheral level as much as the budget government can muster, or we can lobby for a highest possible budget. It should go at least up to the district level or taluka level. That should be the policy, and it should have good emphasis on re-employment also.
Right. So decentralization and re-employment by the government and making a social support. Kindly keep it.
Yeah, just briefly, a point I have experienced with patients, because there are many yojanas now which are running very successfully all over the country for acute management of patients. And when it comes to neurology, if acute management is not followed by rehabilitation, that acute management fails.
Yeah.
At the end of 3 months, that patient would have died of bed sores and urinary infection and respiratory infection. So this advocacy has to be done, that if we don't rehabilitate, that yojana we used for decompression and thrombolysis has gone waste because it was not followed by rehabilitation, which is equally important. And this the insurance people have to know.
Right. So this brings me to, sir.
Also, I would like to comment that even the vestibular evaluations, the test that is from VNG, dynamic visual acuity, video head impulse test, they are not covered under insurance. So basically, when a patient undergoes an acute vestibular syndrome, just to differentiate between stroke and vertigo, they are first taken to the hospital, admitted and done a CT or an MRI in the early phase, and then they're given the medicine and sent across. But there is an underdiagnosed condition that begins there only, because if it is a positional vertigo or it is a neuritis, the neuritis rehabilitation has to start on day 3 itself. And the positional vertigo has to undergo maneuvers. So basically you need to, and also the vestibular evaluation, because there are daycare surgeries where 24 hours you are covering up. So why not have vestibular setups also in the clinics, so that there is more transparency to the patient and in the diagnosis.
Right. Sir, your take on the improvisation of insurance coverage for chronic neurological disorders.
See, the whole problem today is what, all these patients are under the care of, I'm neurosurgeon, they are under care of neurosurgeon. Neurology, they are under care of neurologists. Maybe orthopedic, they are under. So what we do, we send a call to those people. I'll send a call, send this to physiotherapy. Then that physiotherapist, then okay, send it to occupational therapist. There is a need to have in every medical college, as a part of training, a separate ward for disabilities, where once the patient is free from the acute care, he should be transferred under care of those people. They will do the treatment, will be following up medical management. But for the purpose of rehabilitation, there is no separate entity anywhere. If you see, except as it stands today, I think only in Kokilaben, they have a separate setup where patients are admitted under them and they are managing it. Otherwise, there is no such setup anywhere, even in our medical colleges.
Formal structured program as well as a department which takes care, and it is acknowledged by the insurance.
I'll give you an example. If you go past 25, 30, 100 years back, hospital used to have medical ward, surgical ward, gynec ward. That's all. Now you have what? In medical, you have TB ward, you have leprosy ward, you have that ward. There's different things have been created where they are treating those diseases as a disease. Now, if you consider disability as a part of a disease, there should be a ward and separate specialty. Now, because a PMR has been made as a specialty and we have a qualification and degrees, there is a need to have ward under a PMR where all these things will be available. So they will decide who requires what, including psychologists. As far as your insurance is concerned, I don't think today insurance is covering any of these things.
Yeah.
So the government of India or the higher authorities should make it a law. Just as they have made a thing that all these things should be under insurance. They should make that disability and post-op management also should be. Now they are considering only for 60 days.
60 days. Yeah. So that should be an extension.
Yeah. So these are to be dealt at a higher level, and we should be able to pressurize
insurance apathy
on the government to have this kind of disability wards at district levels under people who are experts in that field. That is, the PMR is a medically qualified person. Under him, the whole thing will be there. This is not there. That
Just a
will help.
brief comment, please.
No, just very quickly, this care pathway in the West, if you look at developed countries, it exists. Like from acute care, the post-acute, you go into a rehab unit. And then
Yeah.
from the rehab unit, you go to the daycare centers. Then you go into the home management where therapists visit, finally community reintegration.
Yeah.
So we don't have to model it according to that because of our financial things. But I think those exist. We just now have to start thinking of closing these gaps. We go from acute care to the home, and then everyone is floundering. Nobody knows what to do after that.
Yeah.
So I think it's possible.
Dr. Purva.
I think we are going to tackle and involve the Medical Council of India, because what they say, everybody follows.
Right.
If they say there should be a compulsory for recognition, you should have a PMR ward in every hospital, they will do it.
Right.
Otherwise, it will never happen.
Okay. So
regarding insurance coverage for disability care, there is something called actuarial analysis in the language of insurance. We need to do joint effort with insurance companies of doing the research that if they cover a particular, for example, epilepsy, person suffering from epilepsy wants life insurance or some health insurance. What is the actual risk of that fellow suffering additional burden as compared to someone with not epilepsy? That research, that data has to be shared between the epileptologist and the insurance company, and then only we can negotiate with them, okay, this much additional premium would be applicable to a person with epilepsy and he would be covered for his OPD. The same would be applicable to other neurological disabilities. So we need to do a lot of research and lot of homework for each neurological disabilities. When we plead with insurance companies, please cover this disability, please cover this disability. So homework is needed on all those fronts.
yeah. Actually, the challenge with the neurological disorders, we all know that they are heterogeneous. So to create a uniform model for suggesting it's going to be challenging. But from someone who has been with the people with chronic disorders, especially, I think insurance has totally ignored the oral medication support. And there are medications we know that they are very costly. And to take them for such a long time, either it is epilepsy, MS, Parkinson, it's a challenge. And there is no coverage for these. So how frequent you face such challenge, and how do you try to overcome?
So just for your information, Dr. Purani, Star Health has been doing a special care gold for disabled people, and this has started last month. So if you are not aware, I will send you this brochure. You can contact. It is for specially able. So every disability is being included. Star Health. So if you want anything more, I will share it on the public group. So kindly, please be prepared before you speak. You should know this, that this already has come. I wouldn't have come otherwise.
Yeah, please. Yeah.
Okay, I may not be able to speak much about the insurance questions, but the only point I wanted to make as a sociologist and a person from support group, that after pandemic, there is a very big threat, I would say, to the very structure of a classic support group, because everyone is going for Zoom meetings and online meetings. And what I feel that the actual miracle happens in support group when you face-to-face meet. So I would say that we should encourage face-to-face meet as far as support group is concerned, because nowadays when we go for Zoom meeting, most of the participants feel that abhi video milne wala hai, so they don't even attend online meeting. So to come back to the origin, to the classic support groups, I really sincerely feel that we should encourage face-to-face meeting, and that human touch should not be lost. That's it.
Thank you. You wanted to make a comment?
I want to add on the insurance question somebody asked. The STAR, this is one policy.
Dr.
care
Surya
gold,
sir has really informed about it.
Good afternoon.
My name is Mercy Serra. मेरे डेजी जो अभी 28 इयर्स के है, डॉक्टर निर्मल सूर्या का अंडर में है ट्रीटमेंट में। मैं डॉक्टर सूर्या को ऐसे सोशल वर्कर हेल्प करती हूँ हर एक हैंडीक्राफ्ट वर्क करके। मेरे एक क्वेश्चन ऐसा है, आज मैं मेरे बेटी के लिए कुछ करना चाहती है मगर गवर्नमेंट परमिशन नहीं, उसका एक अकाउंट ओपन नहीं कर सकता है। क्यों? क्योंकि वो फिट्स पेशेंट है और उसका पास सर्टिफिकेट ये है कि मेंटल रिटार्डिंग एज ए फॉर एपिलेप्सी। तो मैं ये चाहता है कि आप लोग ऐसे बच्चे को मदद करो जो उनका बैंक अकाउंट खोले। हम पेरेंट्स कुछ पैसा रख के हमारे बाद उन बच्चों को क्या करेगा, वो लोग कहाँ जाएगा? उनके भाई बहन अगर हेल्प नहीं कर सकता है तो गवर्नमेंट उसको किस तरफ से हेल्प करेगा? और इस तरफ से IFNR हम बच्चों के लिए क्या करेगा? क्योंकि मुझे पता है, मैं आज शायद 12 इयर्स हो गया डॉक्टर के साथ में। डॉक्टर ने कई पेशेंट्स का ऑपरेशन भी फ्री किया है और वो पेशेंट्स के पेरेंट्स जो है बहुत गरीब है, जिनको अफोर्ड नहीं कर सकता है और उनका माँ बाप है, तो अभी उनको एक पैसा रखना है, मेरे बेटा अभी आगे मेरा लाइफ के बाद में कैसे जिएगा। तो वो एक सोच में रह रहे कि पेरेंट्स ही उन साइकोलॉजी इफेक्ट में जा रहा है। तो क्या होता है, पेरेंट्स जब साइकोलॉजी इफेक्ट में चले जाते हैं, अगर पेशेंट घर में परेशान करता है तो उन लोग भी उठा के उसको पटकता है। तुम इट्स राइट इट हैपन। तो इसके लिए हम लोग चाहते हैं कि आप डॉक्टर्स हो या IFNRs हो कि इन पेशेंट्स के लिए कोई अकाउंट ऐसा खोल के रखे कि उनका सेविंग रहे, आगे जाके उनको कुछ हेल्प मिले।
मुझे मैं आपको वो इन्फॉर्मेशन बाद में दिलवाऊंगी, पर मुझे इतना पता है कि जो इंटेलेक्चुअली चैलेंज ग्रुप का, आई एम फॉरगेटिंग द नेम ऑफ द जेंटलमैन, इस पर चर्चा हुई थी ऑफ हाउ ट्रस्ट बनाना है। यू नो, वो ट्रस्ट बना के उसमें पैसे, MFA राइट या, तो वो ट्रस्ट वो हेल्प करते हैं। वो ट्रस्ट कैसे बनाना है, उसमें किसको ट्रस्टीज रखना है। जैसे हर माँ बाप ये सोचता है कि मेरे बाद क्या, ये कॉमन क्वेश्चन है, हर एक से मैंने सुना है। तो पर उसके बाद फाइनेंशियली भी, और एक्चुअली हम काउंसलिंग में पहले दिन से पेरेंट्स को ये बताते हैं कि ये बहुत जरूरी है, अभी हम ट्रीट कर रहे हैं लेकिन इसके बारे में भी सोचना शुरू कर दो कि आगे क्या। तो फाइनेंशियली, मॉनिटरली और जरूरी कि कौन ट्रस्टीज बनेंगे आपके रिश्तेदारों में, सिबलिंग है, उस बच्चे के भाई बहन है, अंकल आंटीज, कौन है जिसको आप इंट्रस्ट करोगे, आप दोगे अपना बच्चा बाद में कि मैं नहीं रहूंगी तो ये लोग तो हैं जो मेरे बच्चे को फिर भी देखभाल करेंगे। तो ये पूरा प्लानिंग के लिए ये बनवाया गया है। आई विल गेट यू द इंफॉर्मेशन, पर ये कैसे करना है, क्या करना है, इसके बारे में सोचा तो गया है क्योंकि ये बहुत इंपॉर्टेंट क्वेश्चन है।
नहीं, स्पेशली मैडम केवल में गर्ल जो लड़की होती है उनका बहुत टेंशन रहता है, इसलिए मैं क्वेश्चन पूछा।
मैं एक शेयर करना चाहूँगी। हमारे पास जितने बच्चे आते हैं जो फिजिकली है, सेरेब्रल पाल्सी है, इंटेलेक्चुअल डिसेबिलिटी है, अगर वो 18 के पहले है तो मैं पेरेंट्स को पहले ही बताती हूँ कि बैंक को बिल्कुल डिस्क्लोज मत करो कि आपका बेटा स्पेशल है। माइनर अकाउंट जस्ट खोल दो। माइनर अकाउंट अगर बच्चे का हो जाता है तो 18 के बाद आपको गार्डियनशिप मिल जाती है बच्चे की। गार्डियनशिप मिल जाती है तो साइनिंग अथॉरिटी आपको ही रहती है, बच्चे का नाम अकाउंट पे रहता है, जो भी ट्रांजैक्शन है वो आप कर सकते हैं लेकिन बच्चे का अकाउंट रहता है। ये दूसरी बात। और तीसरी जो अभी मैडम ने बोली कि आप प्राइवेट ट्रस्ट बना सकते हैं आपके बच्चे की, उसमें आप लीगल एक लॉयर रहता है, CA रहता है, बैंक इसमें इन्वॉल्व रहती है, एक ट्रस्ट इसमें इन्वॉल्व रहती है और आपके रिश्तेदार उसमें इन्वॉल्व रहते हैं। आप जो भी पैसा रखते हैं, घर रखते हैं, उसका रेंट है, उसका रिहैब का है, वो आप सब लिख के रख सकते हैं कि इतना पैसा इसको जाएगा, इतना इसको। और ये 5 लोग हैं, ये मॉनिटर करते हैं आपके बच्चे का पूरा अकाउंट और उसका रिहैब आपके बाद ही वो वैसा ही रहेगा। तो ये प्राइवेट ट्रस्ट आप बना सकते हैं, ये प्रोविजन है। अभी मैंने एक केस हैंडल किया था पूना में। पेरेंट्स 84-82 इयर्स ओल्ड है और बेटा 48 इयर्स और सेरेब्रल पाल्सी है। उसकी बहन यूएस में है। तो हमने पूना में वो सारा उसको विद डिसेबिलिटी सर्टिफिकेट, गार्डियनशिप, प्राइवेट ट्रस्ट पूरा रेडी करके वो बच्चे को रिहैब करने के लिए एक संस्था में रखा है, और वो पूरा पैसा ट्रस्ट के माध्यम से ही उसके पास जाएगा। हो सकता है।
Thank you. Very, very insightful. So, because we are running short of time and we have to conclude, I'll like Mr. Gaikwad to have his final question.
Very
Before we
small, I would like to say, in addition to Mrs. Gandhi and Shah Madam and Mrs. Serov, that hum log, how we are going to manage the money part. As far as Dr. Apurva has said, being a stroke patient, or जैसे कि सूर्या sir ने बताया कि there is now a provision that okay, your finances has been taken care of. But yes, after stroke, what I had faced is that any person who are having any sort of neurological disease or any sort of disability or something, he is definitely devoid of earning the money. ये मेरे साथ हुआ है, मेरे साथ हो रहा है. I myself being a professional lawyer, what I was having my income prior to my stroke was something very different than post stroke. अभी अगर मैं देखता है तो मेरा earnings, it has reduced to 10% or even less than that. So this is one of the area where I am struggling, or many of the people who are with us, they are struggling. So इसके लिए the psychologist, the sociologist और बाकी जो लोग हैं, we are coming up with various conclusions with insurance policies or insurance sector also working on this. But here I would like to add one thing over here. You all are very very specialized in neurological diseases or something. There is one organization or one particular this thing which is working into rare diseases. And since I happen to run into an ORDI run, which was conducted in Chembur, Mumbai, some 2 months back, where I happened to meet with the directors or the founders of the ORDI. So I came to the knowledge that the government is having a special allocation of almost 50 lakh rupees for each patient who is disaffected or whatsoever it is. So these are some of the areas where we need to tap, and the government is having the sources. We as a forum, as IFRCON or something, we need to tap this sources so that everybody, and moreover, another thing which I would like to just for 1 minute, I would like to say that, yes, as a forum where we are seeing that there are social workers, there are trusts, or there are people who are coming up, there is definitely a gap between a doctor and a patient, which I myself has experienced that, which can definitely broken down or which can be reduced. That is what we all should work towards it. So this is what my suggestions are. Thank you.
Thanks for the brilliant suggestions. And I would like to thank all the people who are present and who have attended this panel discussion. Things are not stopping here. I think this is a U-turn which we are going to take from here. Today is a landmark day. We have collected a lot of insights, brilliant ideas, brilliant suggestions. And this is something, the way forward, which we, if you could just reverse your chairs. And this is another vision from Dr. Surya sir, that how we are going to use this information in the future into what all the stakeholders actually feel. That's the felt need. Discussions happening, not translating into actions, not translating into real policies, real change. So nothing which has been said in this room today is gonna go waste. More information will be collected further on in the coming follow-up in the upcoming week. I request everyone to participate and to submit their responses to few of the questionnaires which we would be sharing. We have prepared 3 sets of questionnaires. One is for the medical experts. The other is for the allied health sciences. That is our rehabilitation colleagues. The third one is from the the support groups and the caregivers and the patients. So these three separately will be circulated. Please encourage your peer, your community to give us that feedback, and we'll utilize that in translating that into the action. And I would invite Nalini to dwell upon this.
Thank you, Dr. Manish, and thank you so much, everyone, for this really, amazingly insightful session today. And it is not very often that this entire spectrum of stakeholders come together under one roof. And it is, my privilege to be sitting and hearing all of you. And it's quite a vision, Neurons Ki Awaaz Public Ki Zubani, which actually is, a platform which has been created, and it is in, its nascent stage right now. And the basic premise of this, you call it platform, you call it a national movement, but the entire basic premise is that how all of us can actually, in regular period of times can keep coming together under, one roof, and keep expanding this movement to more information and data driven advocacy, and see the kind of change on various aspects. There's a spectrum of problems, from, demand, supply, insurance, cost, affordability. I mean, you name, an aspect and variable, we have an issue there. And the entire basic premise of this platform is that, how, we can all come together, share our experience and expertise, and bring more solutions, to the problems that we have been talking about. So I am Dr. Nalini Kaushik, and I'm a public policy expert. And my job essentially is essentially and specifically to synthesize, synthesize, all the, insights that you all have been sharing, and build coherence, in everything that has been shared today. And in the next few months, my effort would actually be, in giving a shape to this particular discourse into a more substantive policy paper. And so we would be talking, more about all of this in, in my in some of my next slides. But before we move to that, excuse me. So before we move to that, we have to first understand that, why are we talking about neurological rehabilitation? And I'm sure all of you are, absolutely aware of, why we need that. But I would just reiterate that, there's a profound unmet rehabilitation need around the world, especially in the lower and middle income countries. And this was actually, spoken about, many experts, even Dr. Urvashi, and many people talked about, these aspects today. And it is also pertinent to understand that, the demand for rehabilitation services are increasing, and they will continue to increase due to the various transitions at the national and the global level, such as, demographic transitions, health trends are changing. We have aging population, in fact, in our country as well. And there's an increasing number of people, who are living with diseases and, acute and chronic injuries. So therefore, looking at this entire spectrum of, transitions, the need for neurological rehabilitation becomes really imperative. What neurological rehabilitation can actually, provide? It can provide recovery, it can provide patient well-being, which is, the core of everything, is the core of, why we are here today and, sitting here and talking about all of these things. It is going to reduce mortality and morbidity. It has a strong connection to human rights, addressing stigma, discrimination, marginalization, like so many of you talked about today. Awareness, affordability, accessibility, core pillars, they need to be addressed, and rehabilitation plays a really important role there. And ensuring the economic empowerment to the patients. And I'm sure, the benefits or the reasons of talking about rehabilitation goes, beyond these 6 or 5 boxes that I've talked about. There are a lot of intangible, spillover benefits, why we need neurological rehabilitation. But what gives more structure, at the government level, at the global level, and the national level to neurological rehabilitation? First of all, Sustainable Development Goals, Sustainable Development Goal 3 and 6. 3 is, ensuring healthy lives. It talks about, promoting well-being. Sustainable Development Goal 8 talks about universal health coverage. Then, in 2020, in fact, the 73rd World Health Assembly that took place in Geneva, a unanimous resolution was adopted by the member states, which, paved the way towards intersectoral global action plan on epilepsy and other neurological disorders. In fact, this particular, resolution is, an agenda till 2030, and it is instrumental in shaping the global policies on neurological conditions, wherein neurological rehabilitation is a very integral component. Then, of course, there are international conventions on economic, social, and cultural rights. There are conventions of, persons with disabilities, and, there's right for children, related conventions, etc. Why are we talking, about all of these things? Is that, India is actually a signatory to WHO, to United Nations, and there's an obligation for India as well to formulate such policies which are aligning with all of these principles that are talked here. Now, how does that reflect in Indian scenario? Is that we have a national health policy. It may be deficient, however, there are certain provisions in the national health policy, which talks about expansion of rehabilitative services, health and wellness centers were introduced, all of that. However, I do understand as a public policy person that there are gaps in it, and that is why we are here today. That how can we now drive a data-driven, informed advocacy and get those gaps filled at the government level. Moving forward, okay. So why are we still lagging behind? I don't think there's anything new that I'm going to add here, because all of you have talked so much about it that despite this, this entire global and national momentum that we talked about, there are so many gaps. There are gaps, at the data-driven advocacy level. We do not have, a lot of evidence-based literature. There is interdisciplinary, intersectoral collaboration, which is missing. All of that adds to one critical aspect, that the unanimous voice is not leading to the political level, which is then, not contributing to the strong political will, which is really required to bring this particular change. Now, scientific evidences, patient data, understanding the economic impact. So many of you talked about the culture-based experiences as well. All of that needs to be converted into, scientific evidences, data-driven evidences, so that, we can build cost-effective, sustainable and affordable solutions, and that needs to be reflected in the policy. So those are, some of the areas where we are still lagging behind. Yeah, 5 minutes. 2 minutes, okay. So now, what is the way forward? Neurons Ki Awaaz. Like I just said, it is a platform, it is an advocacy campaign, which is aimed towards building getting the entire spectrum of stakeholders together. So this is the second chapter or the second episode of Neurons Ki Awaaz as a platform that I can, say. First one happened in November last year, and this is the second time. So we are as a policymaker, what I'm trying to do is that I'm trying to generate or collate and build coherence in everything that was talked in the Delhi chapter. Now this is the Mumbai chapter. So I'm trying to, bring more evidences by means of this entire discourse that took place then and now, and it's going to be shaped into a policy paper. Now, Neurons Ki Awaaz, why is it instrumental? Because it is laying the foundation for that gap, which is intersectoral, interdisciplinary, and inter-stakeholder, discourse, which all of us are representing here. We are moving towards more data-driven advocacy, ensuring that no voice is left behind, whether it is a patient or a caregiver, a doctor, OTs, etc. All of us are in it together. Now, just last and the most important point is that the solution is that we as a team are working on a policy white paper. The outcome, I will straight away first talk about, the outcome of that paper. The outcome is that we are planning to do a more national level political advocacy and a media advocacy using that white paper, so that it can lead to, in the due course of time, if done effectively, can lead to a policy change, right? So that is the outcome that, we are intending. What policy change, are we envisaging? Everything that many of you have talked about. If there is an insurance problem, how can we, sort of get certain changes, in an incremental manner, incorporated wherever they have to be. Similarly, awareness problem. How does government need to be part of more awareness program? How systems delivery need to, take place at a more, tier 2, tier 3 cities everywhere. So those are, the solutions, and this white paper is going to be the first step towards all of that. How we are doing it methodology is that after this particular, event today, a set of questionnaire in form of, again, the format that you saw, the scanner code and all, is going to be circulated to all of you and to the entire audience, which is also watching this live on YouTube today. There's going to be a questionnaire circulated, which is specifically designed for specific stakeholder groups. So it is a humble request. We are going to give you ample amount of time, I think a week-long time, to submit your responses, but please take out maybe some 15-20 minutes to patiently respond to those questions, because once we receive that data, it is going to really help us get that evidence building to put together. Also, what we are going to do is that in case to case basis, I am, and maybe the team is going to personally be reaching out to many of you to get more insight, so that we can give that specific shape that needs to be really given to the white paper. That is the formulation part of it. Dissemination is that once that is done, how can we include government and more policy makers into the conversation? How do we get more roundtables with the government? How do we get the seat at the table basically for this particular issue that we are talking about? That's it. This is all what I have to cover. So please take out the time to fill out the questionnaire, and thank you so much. Dr. Manan, over to you.
Thank you, Dr. Nalini. And I know that she has been working really hard. And I would like to thank everyone, because it has got the contribution from each one of you. And this is to be there in the white paper. Now I would like to call upon Dr. Guhan, one of the organizers, to give the vote of thanks.
Thank you, Manish sir. On behalf of the IFNR and the Neuro Rehab subsection of the Indian Academy of Neurology, as we come to the end of this mind-boggling session where all experts have come to under one roof, I am here to propose my vote of thanks. I would like to thank all the participants, both healthcare, patients, caregivers, specifically the stroke support group, Dr. Biplab Das sir, and the stroke support group of India, the patient who participated, Dr. Dheeraj Khurana sir, Dr. Manish Mahajan sir, Dr. Atul Thakur sir, Mr. Mohan, Dr. Deepak Palande, Dr. Kavin, Dr. Urvashi sir, Dr. Vidya Shanai, Dr. Anug Sharma, Dr. Neha Srivastava, patient Jaya, Dr. Apurva sir, and Sonal ma'am, Dr. Jayanti Mani, Dr. Purnima Gauri, and Epilepsy Foundation, the brand ambassadors, Ms. Divya and Ms. Nazia, and Dr. Taral sir, Mrs. Vaishali, Dr. Vineet Jason, and Ms. Sukhvinder, and Dr. Nalini for bringing out the white paper. And most importantly, I would like to thank the moderators, Dr. Manish Mahajan sir and Vidya Shanai ma'am, for actually moderating 18 healthcare experts together. And it is a mind-boggling task to moderate 5 healthcare experts, and I was seeing he could maintain the time and also moderate 8 healthcare professionals. And though I thank on behalf of INR, and it would not be fair on my part to thank my mentor and Dr. Nirmal Surya sir and Dr. Abhishek Srivastava sir, and for 3 things that I wanted to tell, because the moment the patient says that epilepsy is to my advantage, that is the day the empowerment has been truly reached to the patient. And he has taught now the art of empowerment to us and the art of healing to us, which cannot be found in any textbooks. And he has provided the platform here, going one step further in conferences where they only teach us the subject and that's it, it ends with there. But right now here is a platform where not only the public is made aware of this, even the healthcare professionals are made aware of it, that we need to go that extra step, not only to prescribe the medicines, but also that they are made sure their lifestyle is at the maximum benefit, they have derived maximum benefit, and also that they need to be empowered. Thank you very much for teaching me this point, sir. And also Dr. Abhishek Srivastava sir, and special mention to Dr. Hitav sir, because he was simultaneously in the panel here and was acting as a chair in the hall 1. So thanks to Hitav sir as well. Thank you, sir.
So my question, which I put it across before we close and have a group photo. So my question, which I put it across for the Federation of Patients and Caregiver, I want to know that what would be the response from the support groups and the doctors. So if we all today, all the organization join together, get other organization India level come together, all of us meet in 1 month time, and then we frame it out how we go forward. Obviously, this is not a tussle of power. So if those organizations who think that it's a power, and they might well not join. We might work together, and anybody who can take us forward, he should be the leader. That's simple. It's not, should be not that I have 100 people or I have 100 organizations. Anybody who can take us forward on a common goal should be the leader. I'll be very happy even to help from the background. But I think this is the need of our, and this word has not come from me. Let me tell you, this word has come from Matilda from the airport. She said, Nirmal, you do this, and I will help you at European Federation of Patients Association to liaise with you. So it's a great opportunity, because that's the positive thing which has come today to me. And we should not lose this, because she said European Society of Neuro Rehab is not as powerful as Federation of Neurology Association of Patient is powerful, but they are invited in the parliament, not the neurology. So if though they are the part of European Federation of Neuro Rehab. So this is the time we learn this. Once we have alliance with the international collaboration, I think we will be heard everywhere. And once you are recognized outside country, country automatically recognizes you. That's an irony in this country. But let's work on this. So I will wait for response from all of you, all the organization. Let them write to me. So I'll have an Excel sheet, and then we'll also, if you are also aware of other organizations who are like-minded, want to join, most welcome. We are not talking of any finances, any personal gain. We are talking about common goal, working forward, bringing out the common minimum. That Nalini is also helping us out. Manish is also helping out. So let's work on these guys. If this comes, I will feel that this is the most positive point come from this IFNRCON2023. Thank you very much.